First, we'll be learning about psychiatry emergencies followed by environmental emergencies. First thing is the self-harm. It's a very common presentation in UK to the emergency department. So people self-harm themselves and present to the emergency department. Most of them are, or most of these cases basically are deliberate self-harm what they have done. So at the triage itself, it's basically is you need to do a preliminary psychosocial assessment. Basically here, the nurse who is there in the triage will document how the patient appearance is, what is he wearing, how tall he is. That is very important because they are at risk of leaving the emergency department and going out of the emergency department. So they are at risk of absconding. So for this particular reason, you need to do an preliminary psychosocial assessment at the triage itself. Patients who are waiting for the treatment needs to be in a safe environment. What do I mean by safe? It should be supportive. No one should be judgmental, and it shouldn't be too bright, and it shouldn't be stressful, and it shouldn't be distracting. Treatment should be offered for the physical consequences as well as the psychosocial assessment. Basically, why did he have this self-harm? What was the reason for the self-harm? Is there any medical health or is there any mental health issues? You need to offer treatment for the both. Sometimes they might refuse treatment or they do not want to talk about the psychological problem what they are having. They just want the physical injuries what they are having to be treated for. Then you need to respect their wishes and treat for the physical injuries what they are having. Psychosocial assessment, that is basically mental health assessment, should not be delayed unless you are having a life-threatening injury. If you are having a life-threatening injury, then treat the life-threatening injuries first. That takes the priority. If they do not have a life-threatening injuries, both treating and physical injury what they are having, along with treating their mental health issues what they are having, should go hand by hand. So you are treated for the physical injury what they are coming with. Can you discharge the patient? Is it safe to discharge a patient who has come with an self-harm? That's when the sad person score comes in. You do a sad person score and see whether this patient is safe to be discharged. Why are we doing this? Because if you discharge this patient, he might actually commit a suicide, and next time around, you may not be able to restate the patient, and he might be brought dead to the emergency department. For that reason, you need to make sure that if you discharge this patient, it is unlikely that he is gonna self-harm himself or basically he's gonna kill himself. For that reason, they have come up with a scoring which is known as sad person scoring. In turn, it is basically a mnemonic which stands for S stands for sex. Male sex gets 1 point. Males are more prone for committing a suicide. Age less than 19 or more than 45 years. Someone who is very young or someone who is out of the middle age, then those persons are at high risk, again gets a point. Someone who is already diagnosed with depression or has signs and symptoms suggestive of depression or an hopelessness feeling he is having. What is hopelessness feeling what he is having? He feels basically he is useless. He feels I am just a burden on everyone. I'm useless. I cannot do anything. I cannot even carry out the normal activities of my life. That kind of feeling, the hopelessness, what the patient will be having. Depression, there might be few symptoms of the depression, which we'll be learning in the next slides. Mainly loss of libido, loss of sleep or increased sleep, loss of appetite or binge eating. Those kind of features, if present, you need to consider this patient might be having. And depression, it carries 2 points. This is the one which carries 2 points. Previous attempts or any psychiatric care, they are some people are already a known case of depression, or there already might be known case of anxiety problem or bipolar disorder, schizophrenic, all carries a point. Or previous attempt to kill themselves or previous attempt to self-harm themselves or the same thing. One of this following present gets a point. Excessive alcohol use, a binge drinker or an drug user, like for example, he abuses the cocaine. So those kind of patients again gets 1 point. Rational thinking loss, they cannot think properly. There is no rational what is there. Why did you commit a suicide? Because you didn't give me the cake to eat. Today morning I didn't get the pancake, so I committed the suicide. So there is no rational thinking what is there. This is mainly seen in people who are having psychosis or the people who are having organic brain syndrome. This carries again 2 points when rational loss of rational thinking is present. Separated, divorced, or widowed, which is recent. Recent means in last few days or last few months at the max, last 3 months it should have been. Or it is an anniversary which is coming. I have been divorced since 1 year, so it is an anniversary. Today was the day when I got divorced. Those kind of events can trigger them. That's why they get another point. Organized or serious attempts. What do I mean by organized attempt? So it was a well organized attempt. What do I mean by well organized attempt? That means it was well planned. So she planned that no one will be at home at this point of time. So I'll be watching the TV. I'll get so many tablets from this pharmacy and make sure I drink it with and Coke so that I can easily swallow this. And by the time they return back home, I'll be gone. So it is a well organized attempt. Sometimes, usually, what happens is just triggers, and all of a sudden they feel like taking some paracetamol tablets and they take it and gulp some paracetamol tablets. That is not an planned, that is not an organized event. If it is a planned or an organized event, or it is a serious attempt what you're having, it's so serious that you have to resuscitate the patient, then it gets 2 points here. No social support. A social support might be from a family member or a friend or a colleague or from a religious organization or any religious affiliations. So any social support, if present, they do not get an point. If not present, no social support at all. He cannot just go and vent about his life to anyone. Then 1 point. Stated future intent. He'll be like, yeah, you discharge me again, I'll cut my wrist. You discharge me, I'll hang myself. So they have the future intent. They already have, okay, you discharge me, what I need to do, how I need to self-harm myself. They already know it. If the score is less than 6, that is 5, 4, 3, 2, 1, then you can safely discharge. If the score is between 6 and 8 or more than 8, basically any score 6 or more than 6, you're admitting. So intermediate and high risk, admit those patients. If it is a low risk, you can discharge this patient. Okay, it is important. Remember the mnemonic, sad persons, and remember what do they mean by it. Depression. Depression is not a diagnosis which is done in the emergency department. We are really not worried about the depression in the emergency department unless depression has led to an self-harm. How do we deal with an self-harm? We already know about the self-harm. We manage the physical as well as the psychosocial issues what they are having, and we'll do an sad person score before we discharge those patients. So we already have a plan. Someone has a depression and self-harm. What if they have only depression? Then it is not an acute treatment what you're doing. It is not an acute emergency. So depressed patients are not treated in the emergency department, but they might be a part of self-harm where you might have to say the signs and symptoms to decide whether this patient requires an admission or not. So what are these signs and symptoms to call as a severe depression? We are talking about severe depression. If at least 5 of these stated symptoms which are here present for at least 2 weeks, then we call it as severe depression. What are the symptoms which can be remembered with a mnemonic known as CCAPS? So where S stands for sleep. Sleep can be like increased sleep or unable to sleep at all, insomnia. Interest, complete loss of interest in all daily activities. Okay, I love to watch movies. I do not like to watch movies at all now. I lost the interest of watching movies. I like to play the guitar. Now I don't feel like lifting up the guitar itself. Guilt. It's all unrealistic guilt what they are having. I didn't basically unrealistic guilt what they are having. I didn't wash my hand. I feel guilty about it. So that kind of guilt what they are having. Energy, they feel fatigue. They don't feel like carrying out any activities at all. Is physical as well as mental. I do not even feel like watching a movie on the laptop. They feel mental fatigue. It is physical fatigue. I do not feel like going out for a walk. That is a mental fatigue. Sorry, physical fatigue. What they are having. Concentration, unable to concentrate even to carry out a simple activities. For example, you're filling a glass with cup of filling a glass with the water and you spill the water because you're not able to concentrate at all. It was full and it has got spilled now. Appetite might be increased or decreased. Psychomotor issues, agitated or retardation might be present. Suicidal thoughts. Okay, even having a thought of killing themselves or having a plan to kill themselves or some behavioral changes which basically indicates he wants to kill himself. All these symptoms should be present. That means at least 5 of these symptoms should be present for at least 2 weeks to call it as in severe depression. So out of all the symptoms, at least 5 present for 2 weeks, then we call it as in severe depression. Acute behavioral disturbance, it's very important topic. You need to exactly understand what do we mean by acute behavioral disturbance. It is an actually an presentation. It is not an disease. per se in itself. So it is a presentation. Any patient can present with an acute behavioral disturbance. There are various causes for the acute behavioral disturbance, from an substance intoxication and alcohol withdrawal or any substance withdrawal. Hypoglycemia can present, any electrolyte imbalances, severe infection, a head injury, a thyroid storm, heat stroke, seizures. There are various causes for an acute behavioral disturbance, which is also known as ABD. It's a short form for ABD. So what is the depression? It's an umbrella term what you use it. So what is the presentation? How do they present? They might be quite agitated, restless, moving around, pacing around in the room, bizarre behavior they'll be having. They might be very panicky, feared, frightened. Unusual and unexpected strength can be there in those individuals. Usually they're not compliant with the laws of that particular place, and they will have issues with the police. They'll have issues with the ambulance staff, paramedics. They have good pain tolerance. They do not complain about the pain at all. They have very good pain tolerance. They might be profusely sweating. The core body temperature might be on the higher side, rapidly breathing, having a tachycardia also. So all these symptoms, basically what you're seeing, increased sympathetic activity, what you're seeing in these persons. So simply need to remember, a person who is very aggressive and having an increased sympathetic activity is an acute behavioral disturbance. Acute behavioral disturbance, we have already learned from our toxicology previous chapter that a sympathomimetic toxidrome can present like this, an anticholinergic toxidrome can present like this. So for that reason, intoxication itself is an presentation of an ABD. So we do not know the underlying cause. A person presents who is very agitated, restless, sweating, tachycardic, tachypneic, pacing around. It's very difficult to get an history. At that point of time, how to deal with these patients? That's when comes in. If you know exactly the cause, what is causing it. For example, it is an alcohol withdrawal. You know how to treat an alcohol withdrawal. We'll be learning in coming up slides there. You know it is an sepsis. You know how to treat an sepsis. But at that point of time, if the patient is severely agitated, how do you deal with that patient? The guidelines have been set up by an RCAM. So these are the RCAM guidelines, what we are learning. A simplified version, what I have put up across here, which should include everything what is required from exam point of view. So person presents with an acute behavioral disturbance. First, you will be seeing whether it is safe or unsafe. What do you mean by safe? He's just verbally abusing. He's not trying to physically harm anyone. He's holding a knife and threatening you to stab it, or he's spitting on you, or he's just coughing. He's throwing the objects on you. That means he's doing a physical abuse. Your staff, you, including you, are at risk of having a physical injury. If there is a risk of physical injury, then the environment is unsafe. If it is a safe environment, he's just verbally abusing you, or he's just refusing to cooperate with you, and he's just agitating, he's not threatening you to harm, or you see, doesn't have any objects which can cause you harm, or he can cause you harm using those objects. At that point of time, it is safe to go and talk to the patient. Go talk to the patient. Try to verbally de-escalate the patients. Most of the time, it might be a simple reason. He might be really hypoglycemic, or he might be really hungry. He wants a sandwich. Just provide him a sandwich. He'll be fine with it. Or he might be just unhappy with the staff, nursing staff, or the receptionist who is there. Just counsel him. We'll appoint a new nurse to look after you. Take care. In that manner, just try to verbally de-escalate. Ask him what is causing you the trouble. Is it the bright light what is causing, or is the noise in the emergency department, or is the chaotic situation where you are in is causing out? Do you want a sandwich? So in that manner, ask simple questions. Ask him anything which is troubling him. Try to de-escalate. Sometimes they even will be ready to take an tablet if you offer them. Take this tablet, it will make you feel better. Usually we give and benzodiazepine. Remember, our oral tablet is a benzodiazepine what we'll be giving or what we'll be offering here when the environment is safe. Most of the time, it will be an alcohol withdrawal. In alcohol withdrawal, the patient will be so cooperative enough, or patient will be knowing that if I take the tablet, I start feeling better. He will be knowing the diazepam dose, what he needs to be taking. He'll be telling you, doctor, give me 10 mg diazepam, I'll feel better. 2 mg will not act better for me. So they even will be knowing exactly the dose, what is required for him to settle down. Okay, in those situations, you can just give the tablets and he'll calm down, then you can take a proper history. In an unsafe environment where he is holding a knife, where he's spitting on the patients, or where he's threatening to throw the objects and hurt your stuff, or he's just threatening that I'll kill you. So in those kind of situations where it is unsafe, see whether you require an rapid tranquilization or it is required an physical restraint. Most of the time, we do not do an physical restraint in the emergency department because we need to evaluate and see what is going on with the patient. Okay, most of the time, because physical restraint can only be done for less than 10 minutes. Maximum you can do it for 10 minutes. More than 10 minutes is not recommended at all. You shouldn't physically restrain anyone for more than 10 minutes. For example, he is quite cooperative enough for you. Sorry, he's not cooperative enough. You don't know what is going on. Then you need to do a rapid tranquilization. Just doing a physical restraint is useless for you. Coming to rapid tranquilization, we use a drug to sedate the patient. That is basically the meaning of rapid tranquilization. To give this drug, you might have to physically restrain him. That doesn't mean this physical restraint. It is a part of an rapid tranquilization. So just holding the patient to give an IM ketamine, for example, is just and part of rapid tranquilization. It is not an complete physical restraint. Physical restraint is just physical restraint. What you're doing, you're not giving any drugs at all and holding him for maximum of 10 minutes. What you can do that. And this is very rarely we do it because we want to evaluate the patient. You might have to get an IV cannula, collect the blood samples, send it for laboratory investigation, then give the treatment. It takes more than 10 minutes. So what is the first drug of choice to rapid tranquilize? Is the ketamine or dorperidol can be given. But whenever both the options are given, always choose ketamine. Ketamine is the drug of choice. Second line of drug is lorazepam you can give it, or haloperidol can be given. So whenever ketamine or dorperidol is not given in the options, you will pick up an benzodiazepine like lorazepam. In elderly, it is preferred, is the preferred drug in an elderly patient is dorperidol compared to that of the ketamine. Okay, because because this most of these patients are unlikely to have any drug overdose. For that reason, dorperidol is preferred over ketamine. If this patient is already a known case of QT prolongation, or you are suspecting an QT prolongation in this patient, at that point of time, dorperidol can be avoided and given a lorazepam. So remember, in an elderly patient, you're giving lorazepam as the first choice of drug. If that is contraindicated because QT prolongation is present, then you will be going ahead with an lorazepam. Remember, all of these antipsychotic drugs can cause QT prolongation. Haloperidol also can cause QT prolongation. So what is the route what we'll be giving? Most of the time, you do not have an IV cannula, so you end up giving an IM injection. If you have an IV cannula, then IV cannula is the preferred one. Make sure you have an antidote. For example, if you're giving an benzodiazepine, flumazenil is available readily, make sure that. Monitor, you might not be able to connect the equipments, monitoring equipments, but make sure he's in the environment where all the equipments are available. Once it's sedated, you can quickly connect the monitors. Difficult airway trolleys should be present. This is important because these drugs, especially if you're using a lorazepam, can cause severe respiratory depression, resulting in airway compromise. At that point of time, you need to give, you might have to intubate the patient and need to give an antidote. Make sure adequate personals are present. A person who is agitated, only 2% restraining him and giving an IM injection might not be possible. Sometimes, in practicality, at least 5 people will be required to restrain an healthy adult to give an IM injection. So make sure you have adequate personals before you plan to go ahead with a rapid tranquilization. Elderly, we have already discussed here. Most of the time, it is an hyperactive delirium is unlikely. So most of the time, we do not give and ketamine. We like to give and dorperidol. If dorperidol is contraindicated because there is a pre-existing QT prolongation, then you will be giving benzodiazepine as the first line of drug. Most of the time, benzodiazepine will be lorazepam or diazepam what you will be giving. This is again important. Okay, this I don't know, for some reason people tend to forget this. This is again very important, both from practical point of view as well as from exam point of view. We are very fond of labeling everyone as in psychosis, dementia. Basically, a psychiatric disorder is very easy for us to basically label anyone who comes to the emergency department because he's very aggressive. Doesn't make sense what he's telling. He's psychotic. Okay, he has having dementia. That's why he's an elderly person. He's having dementia. No, they may not be psychotic. They may not be having dementia. They may not be having schizophrenia. So they may not be having a psychiatric illness at all. There might be an underlying organic cause. So whenever you're diagnosing a psychiatric illness, it is and rule out what you're doing. There are no particular investigations or there are no particular imaging which will say that this person has this particular psychiatric disorder. It is and rule out what you're doing. What you like to rule out, you need to rule out an organic cause first. Most of the time, if not always, if any one of these symptoms if present, it is the patient will be having an underlying organic cause. Look out for an underlying organic cause. A non-auditory hallucination, most of the time a visual hallucination or a tactile hallucination, is not because of a psychiatric illness. Dysarthria, difficulty in speaking, slurred speech, what he is having, ataxia, incoordination is present, gait, he's not able to walk properly, incontinence, both bowel or bladder incontinence, any focal neurological deficit, for example, like weakness of the right upper limb. So any focal neurological deficit, if any one of this following is present, then you need to suspect there is an organic cause and evaluate for an organic cause. For example, a visual hallucinations. Visual hallucinations are might be seen because of delirium tremens, or it might be seen because of an abuse of a sympathomimetic drug like in cocaine. So think of those kind of things here. There might be a substance abuse or a substance withdrawal might be present, or severe infection might be present. Because of that, the patient is having the signs and symptoms. Now, okay, we are thinking of a delirium. What is delirium versus dementia? What is the difference between delirium and dementia? Delirium, dementia. Dementia is a chronic thing which is happening. Okay, it is present throughout the day. That means it is a chronic thing which happens over and time, usually months, if not years, it takes for the patient to really deteriorate and have dementia. The dementia might be so severe that he might even start forgetting his name. It doesn't fluctuate in a day. That means 1 hour back, you go and talk to him, he was fine. After 1 hour, you go and talk to him, if he's not fine, that is not dementia. That is, you need to think about it might be in delirium. So it is a chronic disorder dementia which takes months or years, there is no fluctuation. Delirium is an acute thing. A patient can develop delirium at any point of time. He's delirious. Why? There are multiple reasons for being delirious. For example, it might be sepsis. That's why he's delirious. Or he might be having alcohol withdrawal. That's why he is delirious. Or any substance abuse. He's delirious. So delirious patients are usually acute. There is an underlying cause. If you can correct the underlying cause, these patients will recover completely. Unlike a dementia patient, for example, someone who is having a Parkinson's has a dementia, it's almost impossible to reverse this. Here, you can reverse it. Along with it, it fluctuates. Now your cause, he's totally disoriented. After 1 hour, you come, he talks like a normal person. So it is fluctuating. After another 1 hour, you go and talk to him, he doesn't even remember his name. So it fluctuates from hour to hour. Sometimes it fluctuates from half an hour to another half an hour. So it fluctuates a lot. How to know whether this patient is delirious or not? The patient, it comes, doctor, usually what the carers or the family members or the friends will come and say, he's not himself. He's disoriented. How do you know? How do you check it? The NICE recommends that use 480. Okay. There is one more scoring known as confusion assessment method known as CAS. This is not recommended to be done in the emergency department. It is usually done in the critical care or in the recovery room post-op. It is not recommended to do it in the emergency department. In the emergency department, the NICE recommendation is to do an 480. 480 stands for 4A's test. It is 4A test. It is A. First A stands for alertness. Next A stands for AMT4 score. Next A stands for attention. Next A stands for acute changes or fluctuating course what the patient is having. First one, let us say, is the patient GCS is fine? Is he alert? He's active. Is he fine? So if you go him, okay, he's alert, he's making a good contact and he's talking to you. That gets 0 point. No, he's sleeping, but you can wake him up and he's slightly sleepy for 10 seconds, then he gets back to his normal self. That usually happens in most of the people. That's why you get a 0 score for that. So if you wake up anyone, he will be slightly disoriented. If he's in deep sleep, he'll be slightly disoriented, but in 10 seconds, he'll be back to his normal self and he'll talk to you normally. Clearly no abnormal. Okay, he's either very drowsy, he's sleeping off in between the chats itself, what you are having, that gets an score of 4. So clearly abnormal gets a score of 4, otherwise 0 and 0. Next one is AMT4 score. AMT4 score, you're asking for the 4 things, that is age, date of birth, place, and current year. Each one gets 1 point. Okay, if he is able to answer everything correctly, then score is 0. If he makes one mistake, then score is 1. If he makes 2 or more mistakes, then the score is 2. Few more things about the AMT score, what you are having here is the current year you are asking. When you are asking the year, ask the current year what you are asking. Place what you're asking, ask the patient, where do you live? That is a place you can ask. Or ask the patient, where are you right now? He must be able to say, I am in this particular hospital. Date of birth is straightforward. Age is straightforward, what you are asking here. Then is the attention what you are having. How do we check for the attention? We'll ask him to just recall the months before the December, November. In that manner, he needs to go backwards and name the name the months. If he can name 7 months correctly, then he gets 0. He can name few, then it gets 1 point. He's not able to name anything at all, or you're not able to check because he's totally disoriented, or he's refusing to cooperate with you, then he gets 2 points. Sorry, refusing to start gets 1 point. If you're not able to check at all because he is too drowsy, he's unattentive, at that point of time, you give it two. Refusal gets 1 point. Or he names few and few mistakes he does, then he gets again 1 point. He names everything correctly, then he gets 0. If there is any evidence of significant change or fluctuation in alertness, cognition, or mental health, okay, if anything over last 2 weeks, if it is present and it is evidence in last 24 hours also, for example, he's paranoid, he's having any visual or auditory or any kind of hallucinations, if he's having, then directly he gets 4 points. So you count all these points, and if he's getting 4 or above points, then you consider, yes, this patient is having delirium. No, he's not getting 4 points, around 1 to 3, then only cognitive impairment might be there, but he's not delirious, what we'll be seeing. So for us, at least 4 points, he needs to get it to call it as an delirium. That's how we actually look out for an delirium. This has been tested. You need to be aware of AMT4 and all the A's, what this stands for: alertness, AMT, attention, where we ask the months backwards, any acute changes of fluctuating course, basically any altered sensory, any paranoia, hallucination, those kind of feelings are there. These are the 4 A's, what you need to remember. This is a 4AT test in the short form, what we call it. There is AMT4 and there is one more known as AMT10 also is present. If you ask me, if you're not good at memorizing, you can skip AMT10 because AMT10 is not very frequently used. AMT4 is the one which is very frequently used. But if you have a good memory and if you want to score really good in the exam, then do go ahead and learn about this. First 4 things holds the same thing. It's the same thing, that is age, age, date of birth, year, what is there. So all these 4 things are present in this individual. Along with it, you need to ask for what is the current time. Identify the two persons who are there. When was the First World War? Current president or monarch in the UK, you need to ask him to count backwards from 1 to 20. Ask him to recall the address given before. That's the house address what you asked here. Ask him to recall the house address what you are given before. This is an AMT 10 score. Here you can actually make out 0 to 3 severe cognition impairment, 4 to 6 moderate, more than 6, then you need to consider there is no delirium. He is delirious, basically you need to consider here. Sorry, there is no delirium what you need to consider, because the score increases as they start answering. So no delirium if it is more than 6. 4 to 6, moderate to severe cognitive impairment, and 0 to 3 is the severe cognitive impairment, what we are calling. Cognitive impairment and delirium or delirious are kind of interchangeable terms. Cognitive is a broader term, delirium is more narrower term, but it kind of interchanged in the emergency department. So here also I repeated telling that possible cognitive impairment. That means it's a mild delirium. We are not sure possible delirious this patient is, but if the score is 4, then definitely this patient is delirious. Now we are entering into the eating disorders. There are various eating disorders. The 4 main eating disorders what you need to be aware of is anorexia nervosa. Anorexia nervosa is usually seen in adolescent age. Around, it will be seen around 13 to 18 is the peak age where you will be seeing an anorexia nervosa. Their BMI will be very much on the lower side. BMI will be very, very low, and this patient will be having low heart rate. This kind of features are usually seen in anorexia nervosa. In bulimia nervosa, it's usually seen in 20s and 30s, commonly seen in females. They feel guilt about what they are having it, and they try to vomit out. Sometimes they kind of stimulate the gag reflex and try to vomit themselves out. Binge eating disorder, this just cannot control binge eating. They keep on binge eating and binge eating. Avoidant restriction food intake disorder is another disorder. Again, it is closely related to the other food disorders what you are having. It is a rare disorder. So broadly, you have an idea about this eating disorders, but we do not label them as an anorexia nervosa or bulimia nervosa or binge eating disorder or an avoidant restrictive food intake disorder in the emergency department. We do not diagnose them. We are not qualified enough to diagnose one of these eating disorders. These are usually carried out by a psychiatrist. So we do not diagnose this. We have a broad idea what it might be. So how do we deal if this patient presents to the emergency department? These patients can present with various complications. For example, anorexia nervosa can present with various complications because he's not having food itself. So severe bradycardia can be there, a severe hypoglycemia can be there in these patients, a hypotension can be there in these patients. How to pick it up, how to know the severity, when to decide for an admission. This has been described in a scoring known as MED score. MED score. What does the MED score stands for? Medical emergencies in eating disorder. So what do they say? They have crisply stated what needs to be done. The first step, what you will be doing, the step one is, have they been formally diagnosed with an eating disorder? Yes, they have been formally diagnosed with an eating disorder. No, you're just suspecting an eating disorder because it is 14 years old, BMI is very low. You're suspecting anorexia nervosa might be there because BMI is also on the lower side, bradycardia the patient is having. At that point of time, you just request a psychiatric review so that they can make a formal diagnosis. Yes, step one is yes. Most of the time it will be yes. They would have been already been diagnosed. Okay. If the patient is medically compromised, should be your second question, is the second step to ask for. These are the factors what you need to actually look out for to see whether this patient is medically compromised or not. Severe low BMI, significant loss of weight, postural hypotension, that is more than 20 millimeters of mercury drop in systolic, hypokalemia, hypoglycemia, hyponatremia, food refusal for food, is just taking less than 400 kilocalories per day, severe bradycardia, hypothermia, raised LFT enzymes, raised liver enzymes, transaminase, raised urea and creatinine, that is kidney dysfunction, abnormal ECG findings are there, suicidal thoughts or any behavior which basically suggestive of this patient having a suicidal ideation. So how to remember this? You can easily remember with a sequence of 1, 2, 3, 4. The first is loss of 1 kg over 2 consecutive weeks. 1, 2. Another 2, more than 20 millimeters of mercury difference in the systolic blood pressure, that is standing and lying down. That is nothing but postural hypotension. Next thing is 3, less than 3 millimoles per liter of potassium. Same thing holds good for glucose also. Sodium again, 3, you have 130, you can remember. Next comes is 4, less than 400 kilocalories. Next comes is again 4, that is less than 40 pulse rate, heart rate. Next comes is 5, 35.55, 35.5 degrees Celsius. So in this manner, in a sequential order, you can remember it. It's an easier way to remember. If you read it twice or thrice and you can write it down twice or thrice, then you can easily remember in this sequential order. So 1, 2, 3, 4, 5. In that manner, you'll not forget it. Along with it, there is a liver enzymes which are elevated, creatinine is elevated, ECG abnormalities and behavior changes, and BMI. BMI particularly remember less than 13. If any one of this following is present, is the patient consenting to treat? If any one of this following is present, you need to admit and treat this patient. Both are required for this patient. Sometimes they may not be consenting. Is he consenting to treatment? Yes, then go ahead and admit him and treat it. It's very easy. No, they have no, they are not consenting. Then mental health assessment is required. We might have to go ahead and do a mental health capacity. Mental health assessment needs to be required, and in mental health act, you might have to restrain the patient and keep them in. This mental health act and mental capacity act we will be learning in our SLO 7 chapters. So just remember here in this chapter that mental health assessment will be required for these patients. Psychiatric chapter, we give antipsychotic medications. We do not usually prescribe antipsychotic medications. It's the psychiatrist or the GP prescribes the antipsychotic medications. One of the most commonest complications or the side effects of giving an antipsychotic medications is having an acute dystonic reaction. This acute dystonic reaction, they can present in various forms. Usually they present with kind of a muscle spasm or kind of an involuntary movement. For example, grimaces he'll be doing. She's just making some faces, facial expressions, though she's not willing to do it. Some facial or mesoidal muscle spasms and trismus might be present. Sometimes it might be a deviated gaze. What you're seeing here in this child, a deviated abnormal gaze. Sternocleidomastoid palsy, or basically rigidity of sternocleidomastoid torticollis can be seen. Sometimes protruding the tongue abnormally outside is known as orolingual dyskinesia or limb rigidity. So these symptoms are fluctuating. It is there for half an hour, it is not there for half an hour. So most of the time you assume that this patient is malingering, he doesn't have anything, but take a thorough history. Once you take a thorough history, if they are on any antipsychotic medications, then yes, you're suspecting. What is another medication? What you need to remember is the metoclopramide. If they are on metoclopramide, also you need to suspect that this patient might be having an acute dystonic reaction or acute dystonia, what this patient is having. So what do you do? First thing, do not give this drug. Stop telling him. Then give procyclidine. Procyclidine is available in intravenous form as well as per oral form. Usually in acute situations, we give it in intravenous form and dramatic resolution of symptoms can be seen. He's having facial grimaces and suddenly everything seems to be normal once you give an procyclidine in the intravenous form. So that fast the treatment is or that fast the recovery is, but this can recur again. That's why you need to prescribe 5 mg of procyclidine and discharge them. Okay, do not just discharge them up because these symptoms can recur again. What about benztropine? Benztropine can be used, but it is not available in the UK. So do not pick this answer as a right answer, no matter in what circumstance you are having. And procyclidine is safe to be given in pregnancy also. So always pick up procyclidine. Is the drug which is available easily in the emergency department. Do not pick benztropine. It is not easily available or it is usually not available in most of the departments. Procyclidine, when you are giving, it has an side effect of euphoria. So look out for an euphoria. Can we give benzodiazepines like in diazepam or lorazepam? Yes, absolutely, you can give it. They are as effective as procyclidine, but sorry, they are not as effective as procyclidine, but it is not preferred. Though it is less effective, still resolution can be seen when you give an diazepam or in lorazepam, but it is not recommended. Mainly, it is not recommended because it has a sedative effect and it can lead to addiction also. At the same point of time, benzodiazepines are less effective. It takes longer time to show the results compared to of the procyclidine. So patient will remain in the emergency department for a longer time. For that reason, diazepams are not preferred. They are less effective and they are addictive drugs. That's why diazepam is not given in acute dystonic reactions. Alcoholic withdrawal. One thing you need to remember, alcohol itself is a substance which causes CNS depression. When you withdraw, that means a person who consumes a lot of alcohol suddenly stops taking alcohol will result in CNS stimulation. He becomes more agitated. Okay, two extremes. Someone who consumes a lot of alcohol causes CNS depression. So he will be very drowsy, non-arousable. He sleeps off in the road because of excessive alcohol consumption. He has not drank from 2 to 3 days because he doesn't have any money. He used to be a binge drinker. Then he becomes severely agitated. He starts having tremors. He starts hallucinating. That is alcohol withdrawal. When do we call it as in simple alcohol withdrawal? Also known simple terms hangover. You must have seen in the movie someone has consumed, I'm having a bad hangover. So what do they present? They usually have the symptoms within 12 hours of stopping of drinking the alcohol. And usually they'll have some tremors, headache, and some anxiety, some sweating, tachycardia, some ataxia might be present, inability to sleep at that point of time. Those kind of features might be present. It's usually seen within 12 hours of stopping of the alcohol. These symptoms are usually commonly seen. Next one is the delirium tremens. Delirious, the patient becomes more and more delirious. It's very commonly seen in 2 to 5 days time. So just you can remember 2 to 5 days. After 48 hours, it is commonly seen. Up to 5 days, it can be seen. 2 to 5 days, what do you need to remember? So last drink was at least 48 hours back. At least 30 hours back is the minimum what you need to drink. He'll have shaking, tachycardia, tachypnea, high blood pressure. He'll be having along with he'll have some hallucinations. He'll start having. He'll feel something is crawling. It's like insects are crawling under the skin. It's a common hallucination. He starts having visual hallucinations. Okay, so this kind of things can very commonly seen in an hospitalized patient. For example, he was been hospitalized because of an head injury, and suddenly after 2 days, you start seeing this patient is hallucinating, profusely sweating, and having a high blood pressure, tachycardia, tachypnea is present. Again, he is hypothermic. Then you need to think this patient is having an delirium tremens. Withdrawal seizures are also very commonly seen in alcohol, commonly seen between 6 to 48 hours. This is a generalized tonic-clonic seizures what the patient will be having. It is not an focal seizures. If the patient is having a focal seizure, think of something else. Again, as we have learned about how to treat the seizure or status epilepticus in the similar manner we are treating here, no changes in those manners. So how do we treat with an alcohol withdrawal? You give an diazepam or you give an chlorodiazepoxide. Both can be given in oral form or can be given in IM or IV. Fluorodiazepoxide is available only in per oral form. Alcohol withdrawal seizures, lorazepam is the preferred one. Indication for the admission in alcohol withdrawal or alcohol intoxication, I'm talking about more intoxication, sorry, not alcohol withdrawal, intoxication I'm talking about. Someone who is alcohol with intoxicated. If the patient is less than 16 years, admit them. Okay, admit this patient because this patient shouldn't have got the access to the alcohol itself. So anyone has forced him to drink the alcohol. So what has happened? We do not know. So admit those patients. Vulnerable patients, for example, the patient is having a Down syndrome or doesn't have any social support. He's elderly, fragile people. If you admit this, if you discharge him, likelihood that he may not be able to carry out his regular activities. That's why you admit at least overnight. You admit those patients. If you feel this patient can go into the withdrawal and have an alcohol withdrawal seizures or delirium tremens, admit those patients. Substance misuse dependency test, a DAS test is available. If possible, you can just remember that. Not very important from exam point of view. Alcohol consumptions. Whenever we ask how many units do you consume, the patient might not be knowing what is unit. So 10 ml of pure alcohol equals 1 unit. That is equal to 25 ml of spirit. That is equal to half pint of beer. That is equal to half glass of wine. Okay, that is 125 ml what we said. Again, do not ask me what is pint. That is in normal language what they use it. Half pint of beer, what they call it, and half glass of wine, and 25 ml of spirit, or 10 ml of pure alcohol, which is not consumed. This is usually used in laboratories. So 10 ml of pure alcohol is equal to 25 ml of spirit, is equal to half pint of beer. It is equal to 125 ml of wine or half a glass of wine. How many units is permissible or it is advised? That is the max what you can take in a week. 14 units is recommended or 3 units per day is recommended both for males as well as females. So for males and females, both they can consume up to 14 units per week or 3 units per day they can consume. When do we call it as in binge drinking? Whenever a female consumes at least 4 units, then it is a binge drinking. A male consumes at least 5, then we call it as in binge drinking. How do you know the person is alcohol dependent? There are various questionnaires available like a KH test, Paddington's alcohol test, PAT test is simply it is known as Audit C. It is recommended by the NICE. Unlikely they're gonna test you on these recommendations or what is Audit C. Unlikely they're gonna test you on Audit C. Those kind of recommendations. Just remember the name Audit C whenever they mention in the stem of the question. Basically, it's a questionnaire which is used to check for alcohol dependence. Limit for the driver, how much he can consume and drive. In a breath test, if you're doing, at least remember the breath test, that is 35 micrograms per deciliter in most of the UK, except in Scotland, where it is a lower range, that is 22 mics per deciliter. What is somatic symptoms and related disorders? They have recently means in last few years, they have combined most of this somatic disorders into one terminology known as somatic symptoms and related disorders. What are the subtypes? What you need to be aware of? Somatic symptoms disorder. They are overly worried about bodily symptoms. They have this pain, they have some ankle sprain, they have some nausea they are having, they feel that they're urinating a lot. They are overly worried about the symptoms what they are having. There is no obvious medical reason for the symptoms what they are having. They're so much and so much worried that their daily activities is affected. Illnesses and anxiety disorder, also known as hypochondriasis. They feel they have a serious illness. They feel I'm having a myocardial infarction, even though you have done an angiography also for that patient. He doesn't have all the arteries are clear, but still he feels I'm having an MI. Doctor, I'm sure I'm having an MI. So he is overly thinking about it and he's excessively getting anxious about it and he's not able to carry out his regular activities. Remember that it is evaluated medically and you have ruled it out. Still, they are worried about it and it is affecting their daily activities and they are becoming more anxious. This is known as hypochondriasis. What is conversion disorder? In conversion disorder, they are having a neurological deficit. It can be a sensory, it can be a motor neurological deficit. Because of this neurological deficit, they feel they are, sorry, because this neurological deficit, you're not able to explain with any condition at all, any medical condition at all. So they are having this neurological deficit. It can be a sensory or motor. You cannot explain with any medical conditions. For example, you can explain with a stroke or a schizophrenia or an Parkinson's or an Alzheimer's. You cannot just explain at all. But he's having this physical neurological symptom that is a sensory or a motor dysfunction. What is factitious disorder, also known as Murchison syndrome? What is this? Okay, first let us see what is factitious disorder. Falsification of an disease. Okay, he or she kind of mimic so that it seems to so that for an doctor it seems that he is having a medical disorder. For example, they keep repeatedly coughing so that you assume that the patient is having a pneumonia. If required, even they will change the x-rays of a pneumonic patient so that you assume that this patient actually has a pneumonia. Those things are done purposefully, it is done, but they do not have gain for it. So they do not gain anything by doing it. If they're gaining anything by doing it, it is known as malingering. Okay, so there are kind of falsification of the disease is done, but there is no gain, then it is known as factitious disorder because they want that sympathy feeling from the persons. In malingering, they have an external incentives involved. Purposefully, they are doing it because they have drunk and driven and they have caused and some nuisance in the society. So they want you to assume that this is because of the psychiatric illness so that they can pretend to be a psychiatric patient. That is malingering. Here, factitious disorder, they do not have any incentives at all. They do not gain anything from it, but still there are falsification of diseases present. That is known as factitious disorder. Psychological factors affecting the medical illness. For example, you give a treatment. The patient says, I'm sure, doctor, your treatment will not work. So this can delay the recovery or worsen the condition what the patient is having. Sure, doctor, you have prescribed me. I'll not take this medication. I'm sure these drugs are not effective for my body. These drugs are not meant for me. Prescribe something else. That means this patient has a psychological factor which will affect his medical illnesses. That is another factor, or that is another component of SSRD. Types of personality disorders. Just remember the bold things that should be sufficient for you to easily pick up what kind of personality disorder it is. Paranoid. He's very much paranoid. He doesn't trust. He's suspicious of everyone who is surrounding him. He might be even suspicious of his close relatives, close friends also. That is paranoid. Schizoid. Emotionally cold. A pet. His pet might be dead. He will be emotionally cold. He'll not have any emotions towards it. A family member might be really sick or passed away. He'll not have any emotion towards it. That is known as schizoid. Schizotypical, they have a magical thinking, unrealistic thinking they are having. They feel that I gonna fly, I have that magical thinking. I know I can go to the Mars. That kind of thinking, if present, that is known as magical thinking. That is schizotypical. Histrionic, he must be the center of attention for everything. Imagine he's in a reception and he wants everyone to talk to him. Everyone praise him. He should be the center of attention. That is known as histrionic. Antisocial, as the term suggests, it is antisocial. They have problems with the law of the land. Okay, at least this person should be 18 years old or older than 18 years, or at least 18 years old they should be. And they have issues with the police. Social rules they cannot just follow at all. Borderline personality disorder. They chronically feel emptiness is there. They chronically feel something is wrong with me. And suddenly they burst open with an anger. That is an borderline personality disorder. Narcissistic. Narcissistic is the person who feels he's the best. I am the billionaire. I gonna be the billionaire. I am the best person. I am the most intelligent person. So I am the best, the best. That is narcissistic. Avoidant. Basically, he cannot mingle with people, unwilling to get involved with any people at all. He just avoids everyone. He cannot have a social relationship at all. Dependent. He is an adult. He cannot carry out. He's dependent for even his day-to-day decisions. What to have in the breakfast, he's not able to decide at all. Okay. Should I drink water? I'm not able to decide. Unable to take resume responsibilities at all. He's not able to carry out even his smaller day-to-day activities. OCD or OCPD, we call it personality disorder, is basically obsession compulsive personality disorder. It is different from an OCD. Here he is preoccupied with the details. He is a kind of perfectionist. He wants everything to be in particular manner. That is known as OCPD. It is different from an OCD, where they have obsession for a thing and they have compulsion for the same thing. They have an obsession that this they have an obsession that this particular thing needs to be done in a similar manner. And this obsession and the compulsion should be present in two different places. For example, this obsession should be present in the home as well as in the school. Then only we call it as an OCD. So OCD is a completely different compared to an OCPD. OCPD stands for obsessive compulsive personality disorder, where he likes to be perfect with everything. He's preoccupied with the details. He wants everything to be in a certain manner, in a perfect manner. That completes the psychiatric emergencies. Before we enter into the Environmental emergencies, let me take few questions what you are having. Do we have the decision to admit a case of severe depression, or we just confirming the diagnosis? Severe depression, why do you want to admit? We It's just an severe depression a patient is, and you feel that the patient has not committed any self-harm, then you are not doing anything. You are just discharging the patient, ask him to follow up with the psychiatrist or the GP. You are not doing anything for that patient in the emergency department. I do not understand what do you want from a borderline personality disorder, or what do you want from a rapid tranquilization. Rapid tranquilization is done for a person who presented with an ABD and is an unsafe. At that time, you do an rapid tranquilization. The drug of choice remains the ketamine. In elderly, the drug of choice will be dorpiradol, sorry. If those drugs are not available, then lorazepam becomes the next one. Borderline personality disorder, he's chronically feels empty and he's at the borderline. So he feels he's not worthless. He feels there is something is wrong with me. That kind of feeling he'll be, and suddenly inappropriate anger he'll be having. Okay, he has chronically emptiness. He feels I do not have enough friends. He feels I'm not in a good relationship. He feels my job is not good. He feels I'm not having a healthy diet. He feels he is not having a healthy lifestyle. That is known as chronic emptiness. Along with in between he'll have burst of anger. Inappropriately he'll get anger for simple things. He'll get anger. That is known as borderline personality disorder. Is a physical restraint a part of rapid tranquilization? Yes, absolutely. Yes, yes. Physical restraint is a part of rapid tranquilization. You hold him to give an IM injection. That is completely an rapid tranquilization. That doesn't mean you're doing a physical restraint separately and doing a rapid tranquilization separately. That's a whole single thing. Occupational, what is the difference between OCD and OCPD? OCPD is basically is perfectionist. He wants the things to be done in a certain manner. Here there is an obsession and a compulsion, which are not realistic. He has an obsession and a compulsion in two different situations. Then it is called as OCD. I don't see any questions, so we'll enter into the environmental emergencies. Again, very important environmental emergencies. Do not ignore psychiatry. Do not ignore environmental emergencies. These are the where you get questions. Last time there were around 8 questions appeared from environmental emergencies and psychiatry. So from this chapter, you had 8 questions which had appeared in your exam. That is 5% of your paper was from psychiatry and environmental emergencies. So first thing what we are seeing is an hypothermia. Hypothermia, a raised core temperature is known as hypothermia. Okay, there are various reasons for hypothermia or raised core temperature. Along with it, there is a failure of thermoregulatory system in your brain is lost. Your brain feels or brain cannot bring down your or brain feels this might be the normal temperature. Okay, it happens over a time. It doesn't happen rapidly, but there is a thermoregulatory failure which is seen. Because of that, the basically core body temperature goes really high. Core body temperature goes really high might be because of an exogenous or an endogenous cause. There are various classifications. This is the classification what we are following here, or I am teaching you guys. It's an exogenous. Exogenous means outside your body the heat is produced. So environmental conditions is the main thing which causes an exogenous heat exposure or exogenous heat production which is there. Because of high temperature, you walk in a desert of 50 degrees Celsius in a Sahara desert or sub-Saharan desert, then obviously you might end up having an hypothermia, eventually leading to an heat stroke. Exogenous, sorry, endogenous. Endogenous means inside your body. It is produced because of increased metabolism. It might be because of a malignant hypothermia or neuroleptic malignant syndrome, increased muscular activities because of seizures, or you're running a marathon, or use of any recreational drugs, especially like in cocaine or an ecstasy, which causes an increased muscular activities where you have an euphoria. So first thing we are seeing is the heat or exogenous heat exposure. Most of the time it is in heat cramps. Unlikely they present to the emergency department. If they present, usually they'll be in heat exhaustion or they'll be in heat stroke. So these are the three different components what you're having. Core temperature is very important for us to differentiate between each of this. So if the core temperature is between 37 to 39 degrees Celsius, up to 39 degrees Celsius also, it is considered as an heat cramp. This is like a heat cramp. Usually you go out in a hot sunny day. What happens? There is a fluid loss. You're sweating profusely. Sweat contains a lot of salt in it. If you taste the sweat, it is salty because it has a lot of salt. So you lose a lot of sodium in it. but you end up having a clear fluid. That is basically you're having an isotonic or hypotonic fluid, what you're having it. That is just the water what you're having. If you just replace the lost fluid just with an water without replacing the sodium, will result in hyponatremia. This is a dilutional hyponatremia, which will eventually cause all the cramps. That's why athletes usually get the cramps if they are not adequately or not timely mannerly, the electrolytes are not replaced. So what's the treatment? Simple oral rehydration fluids, what you are giving it. So or like an ORS, oral rehydration fluids, those are ready-made, like in Gatorade is available readily in the markets. Those kind of fluids will be given and he will be fine. What is heat exhaustion? Heat exhaustion, still he is able to sweat, but he has sweat so much that there is orthostatic hypotension. This is the first symptoms which usually present because of loss of intravascular volume is orthostatic hypotension. Before actual hypotension occurs, orthostatic hypotension will be there. That is the difference between a lying systolic blood pressure and standing systolic blood pressure is more than 20 millimeters of mercury. If present more than 20 millimeters of mercury, then we call it as a postural hypotension or orthostatic hypotension. Along with it, they'll have a tachycardia, no CNS symptoms will be there, IV fluids will be required in these patients, and core temperature will be less than, to be more precise, less than 40.6, but practically we usually take as 40, less than 40 degrees Celsius. The main differentiating factor between a heat stroke and heat exhaustion is the core temperature. So always in the stem of the question, look out for the core temperature. If the core temperature is more than 40 degrees, to be more precise, more than 40.6 degrees Celsius, it is an heat stroke for you. Earlier symptoms very similar to heat exhaustion. Eventually, they'll go into organ failure. It can be a DIC. They can go into renal failure, coma. So MODS can develop. Multi-organ failure can develop in these patients. Whenever a patient presents with an hypothermia, especially presents with an heat stroke, try to reduce the temperature rapidly to 39 degrees Celsius. Okay, as soon as possible, you need to reduce this temperature to 39 degrees Celsius. Then slowly you can reduce it. IV fluids, you need to be very cautious when you're giving this IV fluids because they have a risk of developing a pulmonary edema or a cerebral edema. They are dehydrated, yes, but if you rapidly give IV fluids, then they can develop a pulmonary or cerebral edema. There is no evidence of using any antipyretic medications like in paracetamol. So do not use these paracetamol drugs. They are useless in these conditions. Just do not use those drugs. So how do we treat these patients? If he is conscious enough, give him cool drinks. Okay, undress him, fan him. Tepid sponging can be done. Place ice packs where there is increased circulation is present. That is especially where there are superficial blood vessels are present. They are present in the axilla, groin, and neck region. So place these ice bags in the groin region, in the axilla, because there are large amount of superficial blood vessels which are present there. In an cooperative and in an stable patient, you can think of placing them in an ice bath or placing them in an bathtub where there is ice. This is kind of an controversial thing. Most of the literature do not prefer, or most of the literature do not say don't do it. One thing is you cannot do and monitoring. If it's a really sick patient, very sick patient, giving IV fluids or giving any IV drugs or resuscitating or connecting the just list like this may not be possible. He might get electrocuted. Another thing is once you dip the person in a really cold fluid like ice, it can cause peripheral vasoconstriction and that might hamper with the heat dissipation. For that particular reason, most of the time, it is not the right answer. Do not choose in the examination unless they say he is called cooperative, he is a stable patient, simple techniques are not working. At that point of time, you can immerse him in the cold water. In a cardiac arrest patients, cold IV fluid infusion needs to be done and intravascular cooling catheters can be placed in these patients. Currently, if you ask me, is the only physical methods what you are doing it unless they are in the cardiac arrest. So this kind of physical methods what are really recommended. One method is better than the other method. None of those studies are there or none of those recommendations which are present. Okay, these are taken from the UK ALS guidelines and from the Tintinelli holds good. These are the literatures you can go and refer to them. Next one is neuroleptic malignant syndrome. It is a complication of a psychiatric medication or a side effect of a psychiatric medications. So psychiatric medications, two things we have learned. One is acute dystonia. Now the next thing what we are learning is a neuroleptic malignant syndrome. They classically present with a triad of high body temperature, muscle rigidity, and disturbed consciousness. Dyskinesia is very rarely seen, so you can forget it's a muscle rigidity which is present, hypothermia is present, and disturbed consciousness or altered sensorium what they are having. Along with autonomic instability will be present. So fluctuating blood pressure, tachycardia, hypothermia, these are all autonomic instability what is present. You get all these routine investigations. The special one is the creatinine kinase because of increased muscular activities, because of increased muscle rigidity and increased muscular activity, these patients can have rhabdomyolysis. How do we treat these patients? Immediately stop any antipsychotic medications if he's taking or consuming. If it is mild to moderate, give diazepam or lorazepam can be given. So basically, you're giving an benzodiazepine if it's mild to moderate. If it is severe, then you are giving an dantrolene. So mild to moderate diazepam, severe dantrolene. How do we consider the patient is severe? Hemodynamically unstable. That means hypotensive. The patient unlikely. Most of the time, the patient's core body temperature, if it is on the very much higher side, if the core body temperature is more than or equal to 40 degrees Celsius, consider this as a severe case of neuroleptic malignant syndrome and give those patients dantrolene. The hypothermia methods, what we have learned remains the same. There are no changes with the hypothermia. Cooling techniques fails also, you can consider giving them dantrolene at that point of time. Bromocriptine is not preferred. If at all, if you're planning to give it, you need to contact National Poisoning Information Services. Otherwise, do not give bromocriptine in these patients. If in spite of giving diazepam, give dantrolene, you are given all hypothermic agents you are given or your techniques you are used it till the symptoms are persisting, then you need to paralyze them. For example, give them succinylcholine followed by rocuronium, intubate them and ventilate them. That's the only last resort what you need to use it. So remember, mild to moderate is benzodiazepines, dantrolene is for severe hypothermia, nothing special you do it. Bromocriptine is most of the time wrong answer. Serotonin syndromes. Serotonin syndromes when you take an overdose of SSRIs, select, selective serotonin reuptake inhibitors, or a combination of SSRIs and MAO inhibitors or tricyclic antidepressants. If you're taking these combinations, including and tramadol, okay, including tramadol is an serotonin containing drug. So any of this combination or overdose you have taken might develop in serotonin syndrome. Usually they develop within minutes to hours, they will develop the symptoms. Okay, within first 24 hours, they will develop. Contrary to the neuroleptic malignant syndrome, it takes days to develop. That's an important differentiating factors. Along with their mental status, they're agitated, delirious, comatose, and might be having seizures. Neuromuscular hyperactivity. Hyperactivity is seen. There it was rigidity, like myoclonus, hyperreflexia, tremors can be seen. Autonomic instability is a common factor which is seen in both neuroleptic as well as serotonin syndromes. Investigations are quite similar what we discussed for the neuroleptic malignant syndrome, no changes. How do we treat them? Again, mild to moderate is an benzodiazepine, similar to neuroleptic malignant syndrome. But in serious cases, we are not giving an dantrolene. Here you are giving an cyproheptadine or chlorpromazine is given. Doses you may not remember. It is not required from exam point of view. Either one of this can be given in a severe case. Severe, again, you're looking at the core body temperature. Hypothermia treatment remains the same. No changes. Nothing needs to be done separately. In spite of giving all these drugs and taking up all these measures, still the patient symptoms are persistent. That's when you plan to do an paralysis and ventilate the patient, similar to neuroleptic malignant syndrome. So what are the differentiating factors between a serotonin syndrome and a neuroleptic malignant syndrome? We know what are the drugs. These are the antipsychotic medications here. Here, basically serotonin containing drugs, including tramadol, which is also an serotonin containing drugs. Usually within 24 hours, they develop the symptoms. Here, it takes days to weeks to develop. Myoclonus. This is known as myoclonus. One more clonus. This is known as ocular clonus. These are very specific for serotonin syndrome. Okay. Hyperreflexia is very commonly tremors. This is the tremors what you're seeing here. Hyperreflexia is commonly seen in serotonin syndrome. Bradyreflexia, rigidity, what you're seeing. Bradykinesia or lead pipe rigidity. These are all very commonly seen in neuroleptic malignant syndrome. That's why if you remember our neurology chapter, where I said abruptly stopping and levodopa can result in neuroleptic malignant syndrome. Neuroleptic malignant syndrome is nothing but it's mimicking and Parkinson's, led by rigidity, bradykinesia, bradyreflexia, all are seen in Parkinson's. So neuroleptic malignant syndrome is nothing but Parkinson's, what you're seeing here. It's very close to the Parkinson's. Both are kind of similar to each other. Next one is malignant hyperthermia. It's rarely tested or unlikely to be tested in the examinations because most of the time it is seen or it is associated with general anesthesia. We do not give general anesthesias. It's the anesthetics who give it general anesthesia. So mostly it is tested for the anesthetics. But you need to be aware of this. This is an autosomal dominant disorder. Earliest sign to appear is the masseter muscle spasm. What will happen? Suddenly they'll start noticing that ET tube, there is a bite to the ET tube and they're not able to open the mouth. There is a rigidity which is present. Then they start thinking that it might be a malignant hyperthermia this patient is having. So unexplained tachycardia, raised ETCO2 and tachypnea, what they will be seeing in these patients. So they can eventually result in rhabdomyolysis. They can have tachyarrhythmias like VT, AF, or VF. They can have it, and core body temperature will increase. So stop the general anesthesia. Try to bring him out of the general anesthesia. Support to management what you are giving. Eventually, you will be giving a dentrolin. So dentrolin is for malignant hyperthermia, or also it is used. Next, coming to hypothermia, there is a Swiss stage classification for hypothermia. In hypothermia, if the core body temperature is between 35 to 32 degrees Celsius, usually their physical response will be intact. So they will try to increase the core body temperature by shivering, increase muscular activity that will generate more heat. So they're trying to increase the core body temperature and he'll be conscious. Here, the consciousness level will start fluctuating, all the sensorium will be there and no shivering. The normal physiological response will be lost once the core temperature goes below 32. Between 32 and 28, it is seen. Here, the patient becomes unconscious. Again, the vitals will start getting affected between the temperature of 28 to 24 degrees Celsius. Once the temperature falls less than 24 degrees Celsius, usually at this temperature, the patient will go in cardiac arrest. Unlikely the patient will have any vital signs, he'll go into a cardiac arrest. So what you'll be doing, what is your aim? You're slowly trying to increase the core body temperature around 0.5 to 2 degrees Celsius per hour is the aim what you'll be having to increase the core body temperature. Rapidly rewarming is not advisable because if you rapidly rewarm, they can develop an pulmonary or cerebral edema. Close ECG monitoring needs to be done. If hypertensive, the recommendation is give very small boluses. Usually we give around 500 ml to 1000 ml boluses. But here we are giving 250 to 500 ml boluses, a small half that of the regular doses what we are giving here because they are at risk of developing pulmonary or cerebral edema. Warming techniques, they are passive warming techniques and active. Active, you actually do something, something intervening that goes inside the body is active. For example, humidified oxygen, warmed IV fluids, lavage you are doing, peritoneal lavage or gastric lavage or bladder lavage or in, pleural lavage you can do. Even cardiopulmonary bypass can be done where you will be connecting to an cardiopulmonary bypass machine and basically having and two input and output devices or two input and output central cannulas through which you can do an cardiopulmonary bypass. Again, out of scope of the emergency physicians here. Passive is the main thing, or the first step what you need to do it. Remove all the wet clothings. Dry the patients. Give him a good blanket and hot air blankets can be given. Forced air warming systems are available readily in the emergency departments in UK. Those are known as bear huggers. Warm the room by increasing the room temperature. Increase the room temperature because most of the UK setups will have air conditions. So you can increase the room temperature and make the patients feel better and increase their core body temperature. Hypothermia, cardiac arrest, we have already learned this. Just to stress this, this is very important. Usually a question appears from this table, what is here. We have already discussed about this in the recitation chapter. Frostbite. Frostbite, there are two different classifications. The most commonly followed classification is first degree, second degree, third degree, and fourth degree. It can also be no frostbite, frost nip, superficial frostbite, deep frostbite. They mean very close to each other, but this is the most commonly used one. I recommend this one to remember. First degree. First degree, usually they'll have some amount of paleness and erythema can be there, some amount of edema might be there. In second degree, they start developing blisters. These blisters will have clear fluids. If these blisters are filled with the blood, then it becomes in third degree. In the fourth degree, the skin starts or the tissue starts dying, gangrenous changes starts developing. This is the fourth degree. What you do if someone comes with an frostbite, or what is frostbite first of all? Frostbite is first of all the extremities. If they are exposed to extreme cold, results in this frostbite. Extreme cold, severe vasoconstrictions. Usually the peripheries, the peripheral tissues will start dying. That's what happens in frostbite. So how do you manage an frostbite? Place the injured part in a constant constant 40 degrees Celsius in the water. So basically, you're immersing this hands in a 40 degrees Celsius constant temperature till they become pink. So usually it requires around and half an hour's time. Along with it, give some analgesia because it will be severely painful. Reperfusion will be happening, painful it will be. Sometimes reperfusion injuries can be there, but rarely seen if they have acutely presented to the emergency department. Do we amputate it? Very commonly seen frostbite is there, take a knife and amputate, commonly seen in the movies. Do we do it? We do not do it immediately. We leave it because recovery is excellent in this patients. If you leave it for days together, then you see if there is a clear demarcation and a gangrene has developed very clearly, then only we'll demarcate that part. Usually we allow it to stay for at least a month, then see how is the improvement, then decide on the amputation or surgical intervention. It is not immediately done. Diving emergencies. Diving is a deep sea diving, what we are talking about. So scuba diving, what we are talking about. So you go in the deep sea. UK is surrounded by seashores. So diving emergencies are very commonly seen. What are diving emergencies? Broadly classified into decompression illnesses and barotrauma. Barotrauma is because of changes in the pressure in your body and pressure in the water. Because of the changes in those pressures, barotrauma occurs. There is a descent barotrauma, there is an ascent barotrauma. In descent barotrauma, what happens? The external, uh, the external pressure will be much higher than the internal pressure. So the air or the water tries to move inside your body. In ascent, what will happen? The body pressure will be higher than the surrounding because you're ascending, you're going upwards here. So the surrounding pressure will decrease, but the body temperature body pressure will be on the higher side. So the fluids or the air tries to go out of the body. When the fluid or the air is trying to go out of the body, it will result in a pneumothorax or mediastinal emphysema, nothing but air in the mediastinum. Air in the mediastinum, usually they present with an discomfort, retrocerebral chest discomfort, any neck swelling or an hoarseness of voice they can present with. Descent barotrauma. Descent barotrauma, air is trying or the water is trying to enter into your body in the spaces, especially ear and sinuses. So they can present with an tinnitus, vertigo, or deafness, those kind of symptoms they can present with. So decongestant analgesia should be sufficient. Perilymphatic fistula. A fistula, what you're seeing here, this is known as perilymphatic fistula. Inner ear and the Eustachian tube has a fistula. They can communicate with each other. Inner semilunar circles, whatever, then the fistula has happened there. So they start communicating. Usually the inner ear and the middle ear starts communicate with the Eustachian tube, but there is a hole which has happened. A fistula has happened. This is known as perilymphatic fistula. Here, in this cases, you need to refer to the ENT. Rupture of the tympanic membrane is a traumatic rupture. It heals well. Just prescribe some antibiotics that should be sufficient. So tinnitus, vertigo, deafness, just decongestions, fine. Ruptured tympanic membrane, antibiotic, fine. Perilymphatic fistulas, if present ENT referral, it is a rare thing to happen and it is difficult to diagnose in the emergency department. Sinuses, decongestant analgesia, like how you treat tinnitus and vertigo in the similar manner, nothing different. Pneumothorax, we already know, we have dealt with it in a respiratory and in a trauma chapter in the similar manner. So they basically require an ICD to be placed. Mediastinal emphysema, you need to refer to the CTVS surgeon. Another diving emergency is decompression illness. Decompression illness, decompress. Gases, when they are in extreme pressures, they kind of dissolve in the liquids. The liquid is blood in our body. So they tend to dissolve in the blood and into the tissues. So nitrogen gets dissolved in the tissues and the bloods. Okay, this is known. And when you are descending, ascending upwards, they convert into gas and form bubbles. These bubbles are now in the blood. These bubbles are now into the tissues. Okay, because these bubbles are there in the tissues, they can have various kind of pains. If it is in the spinal cord, it will have spinal cord pain or back pain. If it is in the joints, they'll have a joint pain. If it is in the brain parenchyma, they'll have a headache. So they can present with any symptoms. Along with this, if this air bubble is in the blood, okay, so blood also can have air bubbles, especially when it is associated with pulmonary barotrauma. Pulmonary barotrauma alveoli is ruptured, and that alveoli is ruptured, and the vessel is also ruptured. The air can enter into the vessel, and this air bubbles can go in any part of your body and can cause a stroke. Okay, can cause an ischemia. For example, if it go into the coronary artery, myocardial infarction can occur. Goes to the brain, can cause a stroke. So as I said, Various signs and symptoms from joint pain to gradual pain, any neurological symptom. Chest pains can be seen because of a pneumothorax or coronary vessel involvement, or it might be because of a pulmonary edema. A rash can be seen, but rash associated with itching is a common thing which is seen. But by the time they present to the emergency department, it would have been disappeared. Remember that rash lasts for only 30 minutes, usually associated with itching. And by the time they present to the emergency department, it would have disappeared. Or audiovestibular, like a tinnitus, hearing loss, tympanic membrane rupture can be there. They might just say, I'm not feeling well, like flu-like symptoms they might be having, headache, lethargy, appetite. So they can basically present with any signs and symptoms. The following could not be at an increased risk of the developing. So these are the increased risk of developing. They will be at increased risk of developing an decompression illness or the diving emergencies they might be having if they go really deep in the water and they stay for a very long time and they have missed any decompression stops. So when they are ascending upwards, they will stop. For example, 10 meters they have ascended, they'll stop for some time. Again, 50 meters they are ascended, they'll stop for some time. These are known as decompression stops. If they have missed some decompression stops, or they are dived multiple times in a day, extremes of the age, they have exercised before or after diving, or they have gone to an high altitude because of a flying, or just they have climbed up a mountain or a hill. High altitude, they have gone more high altitude. Any obesity because fat tissue is present, this nitrogen which gets dissolved gets deposited in the fat tissue, then eventually it will turn into an air bubble. Dehydration. So if the patient is dehydrated, especially because of alcohol consumptions, majority, that is 90% of the cases, will present within 6 hours of a dive. So anyone who presents after a diving, always consider it's a diving emergency until and unless proven otherwise. How do we manage? ABCDE management. Step one is to connect to an high flow oxygen. Okay, connect to an high flow oxygen regardless of the oxygen saturation what they are having. Get an X-ray done to see pneumothorax, if at all. If they are dehydrated, get IV fluids. Do not give Entanox. Entanox gets kind of accumulated in air-filled places. That is a contraindication we have learned in the anesthesia chapter. Do not give Entanox here. For that matter, do not give any painkillers also, because they can mask the recompression response. That is, the recovery response can be masked. Do not give any pain killers. If you're planning to give an painkiller, always contact the diving doctor before you give an painkiller. That is the recommendation. If for some reason you want to intubate this patient, inflate the ET tube using an sterile water. Do not inflate it using an air filled, because whenever you're doing an recompression, this air fill can get decompressed and the ET tube can easily come out. That's why you need to use sterile water to inflate the ET tube. Recompression therapy is the definitive. So take home message is step one is always high flow oxygen, or the next step is always high flow oxygen. The definitive treatment is recompression therapy. Recompression therapy is also known as hyperbaric oxygen. What is hyperbaric oxygen? You're giving the oxygen in a chamber which is in under the pressure. So this is a chamber. What is, as I told you in the previous class, hyperbaric oxygen is given in a chamber. This device is not readily available in all the emergency department. So you cannot just say that I need an hyperbaric oxygen because it's a carbon monoxide poisoning. So it is difficult to get it. But in UK, most of the hospitals which are closer to the seashores, they do have an hyperbaric oxygen that is also known as recompression therapy, or recompression, what you are having here. So the patient will be made to lie down in this and kept, and high flow oxygen is given. That is basically this chamber contains an high FiO2 oxygen. That is fraction of inspired oxygen will be on a very much higher side. Next one is a drowning. In drowning, if face is under the water, it is known as submersion. If the face is above the water, it is known as immersion. So this is submersion. This is known as immersion. Drowning deaths usually happens because of suffocation from the submersion in any liquid. It's a suffocation which happens. It's not because of the aspiration. Near drowning survival is basically if they survive even for few minutes also, then they go into cardiac arrest and expire. Still, they call it as a near drowning survival. So what happens basically? There is a wet drowning and dry drowning. Dry drowning, what happens? Whenever you are immersed into an water, laryngospasm happens. Whenever you're completely immersed, or sorry, submerged into the water, laryngospasm happens. That laryngospasm is so severe that no air enters into your lungs, causes hypoxia. This is the main reason the patients die. Sometimes there might be aspiration also because you're in the fluid, you cannot breathe, and you tend to aspirate. This can aspiration, what will happen? The alveoli get filled with the water, not with the oxygen. So the arteries here, due to the hypoxia in the alveoli, start constricting, resulting in hypoxia. Surfactant gets destructed. Surfactant is required to keep the alveoli distended. So if this surfactant is destroyed, the alveoli starts collapsing. Multiple alveoli get collapsed, then it is known as atelectasis. Again, eventually will result in hypoxia. So hypoxia is the main reason for all the issues what you are having in a drowning patient. For that reason, if the patient is in cardiac arrest, hypoxia is the most commonest reversible cause for the cardiac arrest. That's why the recommendation in the cardiac arrest is to give 5 inflation breaths as soon as possible. That is the first thing. Before even chest compression, you're giving 5 inflation breaths. That's the change in the ALS, what is recommended. What are the investigations? ABG is must. You need to require it. Along with aspiration, ECG, for aspiration, you'll get a chest X-ray done. There might be some rhythm changes. ECG is required. Core body temperature needs to be measured. Hypothermia is a common complications, including electrolyte imbalances and hypoglycemia can be seen in these patients. When lifting up these patients, you need to lift this up patients in an horizontal position. If you lifted these patients in an vertical position instead of an horizontal position, can result in pulling of the blood and result in severe hypotension, resulting in cardiovascular collapse. If the patient is asymptomatic and no respiratory compromise is present, that means chest X-ray is fine, ABG doesn't show any hypoxia, then you need to observe for at least 4 to 6 hours before you plan to discharge. If the patient is symptomatic, then you need to admit them for a longer duration. You cannot just discharge. This is a symptomatic treatment what we give, no specific treatment for drowning. There are good and bad prognostic factors for drowning. Very important, tested, I think 3 times it was tested previously in the exams. So you need to be aware what are the bad prognostic and the good prognostic. If the immersion is for more than 5 minutes, it's a bad. Extremes are the age, that means that means the infants, children's, and elderly people. Acidosis on an ABG, coma on admission. These are all bad prognostic factors. There are 4 bad prognostic factors. If brief time, that is less than 5 minutes of infection is present, it's an adolescent or an adult like 30s and 40s, the prognosis is good. Alert at the time of admission, here comatose, here it is adult. Hypothermia kind of preserves your brain. For that reason, hypothermia is good. To have an hypothermia, it's good. Those who are received and rapid on-scene BLS, that means basic life support has been given at the scene itself and responded very well for the initial resuscitation. So they started with the CPR and suddenly they got an ROSC there external at the scene itself. Then you need to expect good prognosis in those patients. Electrical injuries. Usually in electrical injuries, there will be entry and exit wound. Okay. If there is an AC current and DC current we are having, in AC current, usually VF is very commonly seen. This AC, A stands for alternating current. That's why alternating. So it is alternating like this. That's why VF is very commonly seen. DC, this is a direct current. That's why AC systole is very commonly seen. Okay, that's the reason in AC we see VF common, in DC we see AC systole common. Why electrical shocks causes an arrhythmias? Because this is an electrical activity. Heart also has an electrical activity. This electrical activity interferes with your heart electrical activity. That's why in an alternating current you have an VF, in a direct current you have an AC systole. Breakdown of the muscles very commonly seen. Rhabdomyolysis is important complications what you are having. Ophthalmic injuries also can be very commonly seen. Electrical burns to the head can result in cataract or glaucoma on later stage. So any electrical injury to an head, they need to follow up with the ophthalmologist because over a time they can develop an cataract and an glaucoma. So you need to be very aware of. Neurological effects also they might be having like a coma, fits, or headache. So any symptom which is suggestive of a neurological involvement, you need to always get an CT scan done. Asymptomatic patients, normal ECG. So always get an ECG. The investigation of choice in an electrical shock, if it's completely fine, always get an ECG. No significant cardiac history and low voltage. Low voltage is less than 1000 volts is called as low voltage. Then you can discharge. So normal ECG, no significant cardiac history, low voltage plus asymptomatic. Then you can discharge. What if in pregnancy? Pregnancy, like every patient, you get an ECG done along with monitor for the fetal well-being. Involve the obstetricians. It is important. Why? Amniotic fluid is a good conductor of electricity. For that reason, you need to get checked about the fetus. Fetus can get affected, even fetal deaths can be seen. When to admit? Any abnormal ECG, any vascular injuries, loss of consciousness, myoglobinuria, nothing but suggestive of an rhabdomyolysis, significant burns. We have already learned about burns in resuscitation, high voltage injuries like in lightning injuries. Usually the voltage is more than 1000. We call it as an high voltage. Radiation incidents. Radiation, whenever the radiation is, it might be just the exposure to an radiation. For example, X-ray exposure to an X-ray radiations, or it might be an gamma X-rays. So you are just exposed to this radiation. That is known as external irradiation. Or sometimes they might consume an radioactive material. A radioactive material, they can swallow it. You need to differentiate by taking the history. Why is it important to differentiate? It is important because if it is an external radiation, if that person comes out of the place where the external radiations were present, he's not been exposed to that external radiations, and there is no risk for the others who are treating the patient to come in contact with this radiation. But if he has taken or ingested an radioactive material, he has an potential to decontaminate, he has an potential to spread it to everyone who is surrounding him. So contaminated with a radioactive material, still exposed to radiation and needs urgent, careful decontamination, minimizes the risk to himself and other people. So he can contaminate others because he has ingested, or he has, basically his body has been decontaminated with the radioactive material. So that radioactive material will be having those radiations or harmful substances. He will be still having it. He can still spread it and cause harms to the people who are surrounding him or who are treating him. So any irradiated persons like exposed to an X-ray or an gamma rays can have a radiational sickness. That is basically like a flu-like sickness, what they'll be having with nausea, vomiting, some amount of myalgia, some amount of diarrhea will be there. This takes few hours to develop. It will not be immediately developed. Whenever you come across a patient with an radiation incident, involve the ED consultant and involve the radiation physicist as soon as possible. This is an important person, needs to be involved as soon as possible. So what needs to be done in the emergency department if this patient has come with an radioactive substance inhalation or ingestion or an exposure? What you will do not involve any pregnant staff. Tell them don't be close to this person because the fetus will get affected. First is your safety. You treating doctor, your nurses who are treating the patients, their safety is at paramount. So make sure you have been wearing the mask, you have been wearing the plastic aprons, two pair of gloves you need to be wearing. You must be wearing rubber boots before you see these patients. Then for the patient, you will be doing wet decontamination. Before doing wet decontamination, you need to remove all the clothes, everything, and pack it in a glass. And anything you are used from medical equipment, when swab you are used, you need to place it in an decontamination room. Before placing them, place it in the plastic bag, then place it in the decontamination room. Then all is symptomatic treatment, what you're doing. If any life-saving treatment is required, you'll be doing. So it's a symptomatic, no specific treatment exists for it. Instruct patients and staff not to eat, drink, or smoke. That can cause more harm. Okay. So no pregnant lady. First your safety, then wet decontamination, then treat the patient, whatever life-threatening features are there. For staff, including you shouldn't drink, eat, or smoke till radiation physicist comes in and takes an active intervention. So whatever and all specific things needs to be done, it is done by radiation physicist. So we'll go through the questions before we enter into the recall questions here. How rapid warming causes pulmonary edema or cerebral edema? Rapid warming, what happens when you warm? Okay, basically arteries and veins starts distending. The vasoconstriction would have lost. That will result in cerebral or pulmonary or any edema in any part of the body. So you're rapidly rewarming the patient. It is important to differentiate between a dry and wet drowning. No, it is not important. The two pathophysiologies, what happens, you cannot differentiate which one has caused an hypoxia. But either ways, dry or wet, what you're having eventually will result in an hypoxia. The takeaway message is hypoxia is the main cause in these patients, not an pulmonary edema, not an aspiration. It is the hypoxia which causes the deaths in these patients. So we'll enter into the recall questions what we are having. So we are having a middle-aged person who are fell into the water drain. He is submerged basically. They're asking in submersion, what is the poor prognostic factor? So out of this, which is one is the pro prognostic factor what we are having is the duration, because he has submerged for 10 minutes. Anything more than 5 minutes is taken as a bad prognostic factor. Sex. Sex is not included at all. Comorbid is also not included. Tachycardia is not included. Blood pressure is also not included. So the poor prognostic factors is immersion for a longer time, that is more than 5 minutes. Extremes are the age. Acidosis, that is pH less than 3.5 if you are having. 7.35, less than 7.35, sorry, or the patient is comatose at the time of admission. A 32 years old male was recently diagnosed with schizophrenia, was started on the treatment by his GP. He has presented to the emergency department with profuse sweating and agitation. On examination, the GCS is fluctuating, so altered sensorium is there, increased muscle tone, that is rigidity is present, and there is tachycardia, and there is an high core body temperature. So this patient is having an classical triad. What we are seeing a classical triad: hypothermia is seen, altered sensorium is seen, and muscular rigidity is seen in the setup of an schizophrenia antipsychotic medications. So we are thinking of a neuroleptic malignant syndrome in these patients. A 37 years old female presents to the ED with her tongue protruding involuntary out. She's worried and annoyed with it and is seeking medical remedy. She was recently been diagnosed with schizophrenia and started on the medication, that is antipsychotic medications have been started. Been taking this medication regularly, not missed any dose. What is the most appropriate? What is happening is an involuntary movement with that involuntarily protruding the tongue out. It's not a voluntary. In a setup of an antipsychotic medications, we need to think of an acute dystonia. In acute dystonia, drug of choice is procyclidine. So the right answer here is procyclidine. Young patients present to the ED with palpitations, agitation, confusion, sweating, shivering. She has had a tooth extracted and the dentist has prescribed tramadol for the pain. Tramadol. She is taking citalopram regularly for her depression. On examination, you can see the core body temperature is increased. There is tachycardia and there is a certain amount of tachypnea is also present. Citalopram is an SSRI. Tramadol also contains serotonin. So combination of an SSRI and a tramadol has resulted in an serotonin syndrome in this individual. How do we treat an serotonin syndrome? Serotonin syndrome usually give benzodiazepines for mild and moderate. Lorazepam, what will be giving? This is not mild or moderate. It is a severe because of the core body temperature being 41 degrees Celsius. For that reason, we are giving cyproheptadine. Okay. Dentrolin is not preferred in this cases. Dentrolin is usually given in neuroleptic malignant syndrome or in malignant hypothermia. A 34 years old male present to the emergency department trying to fix an electrical switch and resulted in an electrical shock. Okay. There are no other injuries sustained. Vital parameters are within normal limits. Which one of the following investigation must be done before you plan to discharge the patient? ECG is a must because this external electricity can interfere with your cardiac electrical activity, resulting in arrhythmia. That's why ECG is a must before you discharge. Which one of the following is correct regarding the borderline personality disorder? So each one of this will be seeing unwilling to get involved with the persons is known as avoidant. So this is an avoidant personality disorder. Grandiose sense of self is nothing but narcissistic behavior what the patient is having. So this is a narcissistic behavior. Sensitive and behavioral changes what we are having. So borderline personality disorder is quite sensitive and having a behavioral changes. This is borderline personality disorder. What about magical thinking? Magical thinking is stereotypical, we call it. What about unable to assume responsibility? He is nothing but dependent. So sensitive behavioral changes is very commonly seen in borderline personality disorder. A 40 years old male was brought by the police to the emergency department. He has not been allowing nursing staff to check his vital parameters and secure the IV line, verbally abusing and physically assaulting the staff. The nurse in charge requests you to immediately review the patient. The patient is sorry. What is the next step in management of this patient? So this patient has an ABD presentation because he is quite aggressive. He's verbally abusing and physically. So it is an ABD presentation. Is safe environment and unsafe? It is an unsafe environment. In unsafe environment, what will be doing? Rapid tranquilization will be doing. Drug of choice for rapid tranquilization is ketamine. Is ketamine given here? It's not given. So second line of drug is lorazepam. Is lorazepam given? Yes. So we are selecting lorazepam here in this patient. Similar question, not cooperative, spitting on the staff. Spitting on the staff is also needs to be considered as an physical thing because it is spitting. He might be an HIV positive and spitting on you. You do not want it on your staff. So it is an unsafe environment. Again, this presentation is an ABD in an unsafe environment. So rapid tranquilization, what we are planning to give. What we'll be doing for the rapid tranquilization, ketamine is the first choice. It is not given ketamine here. That's why we are choosing lorazepam as the choice here. Again, aggressive towards staff and agitated. He's a known drug abuser and an alcoholic addict. The nurse is unable to check the vital parameters and he's completely uncooperative. What is the most probable diagnosis or the presentation they're asking? Let us rule it out. Schizophrenia. Schizophrenia usually they present with an paranoia or they present with an psychosis. So it is in paranoia. Usually they would have been already been diagnosed by 70 years. Unlikely a 70 years old presents within schizophrenia. Bipolar disorder, again, they would have diagnosed, and manic attack can present in this manner. But unlikely, nothing is mentioned in the questions here. Dementia is a long-term history will be there, not an acute thing, so we can rule out and dementia. Alcohol intoxication, I can see few of the people have picked up as an alcohol intoxication. Can alcohol intoxication be aggressive? Alcohol withdrawal. So what is the difference between alcohol withdrawal and alcohol intoxication? Alcohol withdrawal can be aggressive. Alcohol withdrawal is not aggressive. The seen as depression is seen. They'll be very drowsy. They would have slept off. So aggression is seen in withdrawal. Withdrawal is not given here. So the presentation is an ABD presentation. The cause is still not known. So it is an ABD. That is stands for acute behavioral disturbance. This question simply asks you what is not included in a sad person score. Sex is included, no social support is included, previous suicide attempt is included, depression is also included, Crohn's disease is not included. So it is a straightforward question, Crohn's disease. So you need to be aware of sad person score. They like to test in the exam as well as in the OSCE exams. A young female present to the ED department with complaints of generalized weakness and dizziness. She has no medical issues, is not on any prescribed medication. There is no history of there is a history of separations from her husband 3 months ago. The vital parameters are within normal limits. According to the sad person score, what is the cause of her symptoms? Sad person score they are asking. They are not asking about depression here. So do not get confused. In sad person score, for her, most likely cause is suppression what she had. So most likely it is a suppression and diverse what the patient is having. Because of that, she is having this symptom. So sad person score accordingly, it is in suppression and diverse. A elderly female was brought to the ED by an ambulance from an care home. Carers complained that she has been confused, agitated, aggressive towards the staff since morning. In emergency department, the patient is verbally abusing the nursing staff. On examination, she has an abnormal gait. Her observations are as follows, which is stable. What's the likely cause of her condition? So what is the likely cause here? Anyone, what is the likely cause? The takeaway important point here is the gait. Gait is abnormal. So we need to think of an organic cause. Okay, other than psychiatric cause, what you need to think of. So bipolar is a psychiatric disorder, functional psychosis, psychiatric, schizophrenia, psychiatric, dementia also is a more of a neurological and psychiatric disorder what you are having. Intoxication, substance abuse is an organic cause. Abnormal gait, suggestive of an abnormal cause. Abnormal gait or attacks or dysarthria or non-auditory hallucination or incontinence or new focal neurological deficit. All you need to suspect an organic cause. So the right answer here is intoxication. A 33 years old male present to the ED department with headache, vertigo, and severe pain in the muscles and the joints. There is a history of travel to Maldives for deep sea diving. So it is an diving emergency we need to consider. Again, immediately he has taken a flight. So he's higher risk. He has gone deep sea and then he has taken a flight high altitude. He has gone. So he has come in here, hence from the UK to the emergency department immediately. And what's the next step they are asking? So what is the next step for the treatment? Always high flow oxygen. What is the definitive management? Is the recompression therapy. It takes time to start the recompression therapy. You need to shift it to a decompression room. Then only you can do it. So start a high flow oxygen, then refer the patient for a decompression therapy. That is nothing but for hyperbaric oxygen. A 25 years old male present to the emergency department with multiple vague symptoms. There is an history of traveled to the Florida for a deep sea diving. Soon after deep sea diving, he took a flight back to the UK, and in the flight itself, he started having symptoms. Hence, arrived to the immediately presented to the emergency department. You are suspecting decompression illness. Which one of the following symptoms is least likely to be present or least likely to have? He can have joint headache, weakness, dizziness, itching also can be present. But this patient has gone from the Florida and come back. That means from USA to UK, usually it is a 10 hours flight. So he has traveled for 10 hours. This itching and plus rash usually lasts for only 30 minutes. So unlikely he presents with an itching. So this is the right answer here. He can present with joint pains, headache, weakness, dizziness, but can't or usually doesn't present with an itching. Her tongue is protruding involuntarily out. She is on metoclopramide. Along with antipsychotics, metoclopramide causes acute dystonia. Treatment of acute dystonia, they are asking here, it is procyclidine. Aggressive, verbally abusing the staff, difficult to manage as he doesn't cooperate. He's an elderly person that is 87 years old. He has brought to the emergency department from a care home. The staff are concerned that he is ill and he's quite aggressive, verbally responsive, verbally abusing, and is difficult to manage. Which one of the following is an appropriate initial management step? Is it safe or unsafe? First thing question. It is a safe situation. It is not an unsafe situation because he's just verbally abusing, he's just being aggressive, it's difficult to manage. So it is a safe thing. So why he is having these things, what he is having? Just check. It might be hypoxia. Hypoxic encephalopathy can cause it. That's why checking oxygen is important here. Than taking drastic steps like doing an intravenous or physically restraining him, which is not required in this situation at all. Intravenous lorazepam. You can take time and see what is wrong with this patient. That's why checking vital parameters like an oxygen saturation is an important step. Then you can decide, no, this looks like an, for example, alcohol withdrawal. So I want to give him some diazepam, offer him some oral diazepam, then going intravenously. A 30 years old male was brought to the ED department by the police. The emergency department, in the ED, the patient is agitated, aggressive towards the staff. He is a known alcoholic. He last drank 2 to 3 days back. So it most probably it is an alcoholic withdrawal what the patient is having. There's slight amount of tachycardia is present. The BM is slightly on the lower side also. What is the next step in the management? Can the question remains here is, can this patient, the hypoglycemia what we are having 39.2, can result in agitation? No, unlikely. If the hypoglycemia is around 2.5, then the patient becomes very disoriented and neurological symptoms develop. So around at least less than 3 should be to develop. At this levels of sugars, these symptoms are not seen. So first give him some diazepam orally, then you can see how he's responding, and then you can treat the hypoglycemia what the patient is having. So the right answer here is to treat the alcohol withdrawal first. The presentation complaint or the presenting complaint needs to be treated. Later on, this patient will definitely requiring thiamine plus dextrose infusion. A middle-aged man was found wandering in the streets and swearing at the public. He was brought to the ED by the police. He's agitated and aggressive in the emergency department, was tried to verbal disciplinate, which was ineffective. He's threatened to physically harm the staff. 4 people are required to restrain him. What is the next step? What do you do for this next step? Each one of these questions will be seeing. Next step should be ketamine here because it is an unsafe. He's trying to physically harm this patient. Is ketamine given? Not directly given here. Haloperidol and promethazine can be given, but it's not a first line of drug. Sedate till you achieve the appropriate level. Yes, this is an appropriate sentence. Restrain him in the prone position for 20 minutes. Absolutely not. 10 minutes is the recommended time. Prone position is not recommended at all. There was a case in the US where the prone position, they restrained, inmate, I guess, was restrained by the police in the US in the prone position, resulted in death of that patient. So never restrain a patient in a prone position. Request senior doctor in the staff for verbal de-escalation. You already tried and he is in the physical harm state here. So verbal de-escalation should not be tried now. It should be a rapid tranquilization. Lock him in the room. Absolutely not. That will be against the right of the patients. So set it till you reach the appropriate level is the right answer. We have a middle-aged person came to the ED by the police, found outside in pub, disoriented. In the emergency department, you're not able to collect his appropriate information as the patient is disoriented. Old records are not available. Sorry. GCS is around 12 to 13. What is the most appropriate next step in this management of this patient. What you will do for this management patient? He's just disoriented. What you will do? A patient who comes, check the vital parameters. That is, first thing I would have done is check for the vital parameters. Vital parameters have not been given. What else I'll do? Along with the vital parameters, usually as a routine, I'll check for the BM, sugar levels. Because hypoglycemia can present like this. Consumption of alcohol can cause hypoglycemia. It is in pub setup. So checking the high glucose levels should be the first thing. What about alcohol breath test? This patient is disoriented. For an alcohol breath test, they need to make for alcohol breath test, they need to blow through an mouthpiece. So good seal for the mouthpiece is required to make test this one. So alcohol breath test cannot be done for these patients who are disoriented. Who can cooperate and listen or obey your commands, only those patients can be tested for alcohol breath. A worried mom gets her 15 years old child to the emergency department with complaints of low mood. She denies any suicidal thoughts. It is important first, denies any suicidal thoughts. On further questioning, she says it all started when she scored low in the examination and all her friends got good marks. She's currently planning to join the college. What is the next best step in management? Is there anything to worry about? This is a normal response. Whenever you have an exam, you get a low. This is a normal response. If I get the low marks in my exam, I'll feel bad about it. Especially when my friends, all of them have passed, and if I have failed, I'll feel bad about it. So I'm feeling bad about it, having a low mood. It's a normal thing. So discharge her with a self-advice at home. So don't worry, this is a self thing, this is a normal thing. So self-advice, how to cope up with this things, what you encounter in your life, you'll just explain them and you just discharge them. Doesn't require any psychiatric, absolutely not any SSRIs, no, absolutely not. It's a normal thing. Admission also not required. Well-being, child well-being also not required. A 85 years old male was brought to the ED by the police. He was found wandering around in the park alone. On arrival to the emergency department, he looks disoriented and his vital parameters are within normal limits. No old records of the patients are available. So you decide to do an cognitive test to further evaluate him. Which one of the following includes or included in 4AMT? Which one of the following is included in the 4AMT is the basic question here. So 4AMT includes what? What are the components in the age is the one component. Date of birth is the another component. Place, what we'll be asking. Usually where are you now, you'll be asking. And year, the current year, what you'll be asking. Out of this, date of birth is present. That is the right answer. This is the four things what I explained. Is the same four things. Which one of the following is suggestive of somatic symptoms? Somatic symptoms they are asking. Extremely focus on physical symptoms, which usually interferes with their physical activities, is an somatic symptom. Four different size, two GI symptoms, one sexual symptoms is a somatic symptom disorder. Excessively unduly worried about having a serious illness. What is this? Hypochondriasis is what the patient is having. Symptoms of the same illness repeatedly. No, this is something different. Dissociated and characteristic of nonsensical or wrong answer to the question. This is also nothing, or it is not an SSRD. Lack of emotional access is also not an SSRD. He's a known alcoholic. Complaints of purple color, visual hallucination with agitation. He has not consumed alcohol for last 2 to 3 days. On examination, he is having an high core body temperature. He is having a tachycardia and tachypnea. What is the most likely diagnosis? More than 48 hours, one criteria is satisfied. Core body temperature is on the higher side. Visual hallucination is present. This is delirium tremens. It's a straightforward question. A pregnant lady had an electrical shock. Best management plan for her. She is completely stable and asymptomatic. She doesn't have any symptoms now. What we'll be doing? Minimum for any patient is ECG. As she is pregnant, you need to review the fetus also. So obstetric assessment and ECG is the right answer here. Agitated and aggressive towards staff, BM is on the normal state. What you will be doing? He is a known alcoholic. So we are suspecting an alcohol withdrawal. Alcohol withdrawal, give him some diazepams or basically benzodiazepines like lorazepam. Here lorazepam is there. We are choosing lorazepam. Is the same question here again. The BM I have put it up on the lower side. Same question, agitated and aggressive what we are having. He is a known alcoholic if I'm not wrong. Yes, he is a known alcoholic. Same agitation and aggressive. BM on the lower side. What we'll be doing? How low is the BM? If the BM was 2, I would have given thymine plus dextrose. If the BM is 3.9 or anything more than 3, I will give him lorazepam because I'm thinking of more of an alcohol withdrawal. So treating the alcohol withdrawal here will be the right answer. That is the first one. Here we have an 46 years old who had been on a Sunday, hot Sunday day. He has gone for a marathon run in the emergency department. He brought to the ED in the ambulance. He has collapsed while running. On arrival, he was rescued in the resuscitation bay, connected to the cardiac monitor, and IV canal has been secured. Tachycardia, tachypnea, core body temperature is 41 degrees Celsius is present. Which one of the following is the most appropriate step? Directly admission is never most appropriate. We never give warm boluses, or directly we do not give any boluses in these individuals. We give small boluses, 250 to 500 ml will be giving if required here. It's not required to give large amount here. It's maintaining blood pressure. So this is also a wrong question. Increase room temperature. No, reduce the room temperature because it is hypothermic. Ice water immersion is most of the time it is not the right answer. As I told you, ice water immersion should not be done in the individuals because of various reasons. Some studies have even shown that it's not an effective thing because of peripheral vasoconstriction. So the right answer here is rapidly reduce the core body temperature to 39 degrees Celsius. That should be your aim. You're suspecting an serotonin syndrome. Which one of the following is the most specific for an serotonin syndrome we are asking? Cogwheel rigidity, neuromuscular disorder, QT prolongations, not seen at all. Focal neurological services, not specific. Core body temperature more than 40. We have malignant hypothermia, neuroleptic malignant syndrome, serotonin syndrome, heat stroke. All can be seen in this core temperature being more than 40. Ocular clonus. Yes, it is very specific. Clonus is very specific. Increased muscular activity is very specific for serotonin syndrome. Basically, submerged in and water drain, good prognostic factor. Read closely or carefully. It is a bad or good prognostic factor what they are asking. So out of this, which is the good prognostic factor? Received rapid, received rapidly BLS on the scene and there was a good response. Comatose on admission is bad. Severe acidosis is bad. Extreme of age, bad. Immersion for more than 5 minutes is also bad prognostic factor. A 26 years old female was brought to the ED from a pub by her friends. Friends give an history of alcohol consumption. On examination, there is some amount of tachycardia and tachypnea. Hypotensive, the patient is. Hypothermia also is there, some amount of. Pupils are 3 mm and bilaterally reactive. What is the most, which one of the following is most appropriate? What you'll be doing in this patient? Consumption of benzodiazepine with alcohol give flumazenil. So do you think there is an consumption of benzodiazepine in this patient? Unlikely, and benzodiazepine consumption usually will cause an hypertension. Okay, benzodiazepine usually causes CNS depression and RS depression here. Okay, RS depression is not seen, tachycardia is seen. So it is not an benzodiazepine what the patient is having. Consumption of opiates, again not opiate, pinpoint pupils of 3 mm of normal size. Fomipizole, usually they are in a pub. If they would have told a country alcohol they had it or something manufactured in the home alcohol they are had it, then you would have thought of methanol overdose or some ABG was given, some acidosis was present, then you would have thought of methanol. Then we give anfomiprazole. This doesn't say anything in the sort. Diazepam. Diazepam doesn't make sense giving diazepam at all here because this patient is not agitated, not aggressive, where there's no ABD presentation here in this patient. Giving normal saline makes more sense because the patient is hypertensive. So we are going according to airway, breathing, circulation, deformity. We don't know what's the cause. Alcohol is consumed. Alcohol can cause hypertension because of increased urination. So we are treating in circulation. We're giving an IV fluid for this patient. That's how you need to rule out and just come out with the options what we are having. So just do not blindly pick up the options what we are having. Okay. Fomipizole, I see most of you selecting the fomipizole. Again, fomipizole, the classical history should be present to think of an methanol intake. Okay, just alcohol intake, fomipizole will not give. Ethanol will not give fomipizole for those patients. A elderly female lives in a care home. She was brought to the emergency department in an ambulance and care complained that she is confused, not cooperative and daily, and her observations are in the emergency department are normal limits. She is cooperative with you. Which one of the following will help you with the assessment of the confusion? Confusion is nothing but delirious or delirium. Which one of the following will help with the delirium here? EEG is never done in the emergency department. Okay, that is never a right answer for anything in your exam. ECG is for cardiac. Mental state examination is completely psychiatric assessment. What you'll be doing, you'll be doing in asking. Mini mental state examination is more for the dementia. What you'll be checking for. AMT is the more right answer here. Abbreviated mental test. AMT 10 will be doing if you want to do singly. Otherwise, we'll be doing 480. Preferred one is the 480, or recommended by NICE guideline is the 480. A 15 years old female was brought to the emergency department with complaints of visual hallucinations. Dull, not mingling with people. She gives an history of menorrhagia. Her vital parameters shows there is certain amount of tachycardia is present. What is the most likely cause for her symptoms? The two ways of thinking, keeping the age in mind, you can think of anorexia nervosa. Okay. Keeping menorrhagia in mind, you can think of anemia. They are the two things which are present here. Two things which are present here, eating disorder and anemia. Rest of the things you can easily rule out. You're not thinking about here. Keeping the age in mind. I would recommend you to choose an anemia over an anorexia nervosa here. The main reason is blood loss. Menorrhagia is increased menstruation or increased blood loss can cause anemia. Anemia can cause tachycardia, visual hallucinations, though very rarely seen visual hallucinations, is not commonly seen visual hallucinations. Dullness and mingling can be seen, or not mingling with the people can be seen. Why I'm not choosing anorexia nervosa? In anorexia nervosa, very commonly visual hallucinations are seen because of electrolyte imbalance, but it doesn't cause menorrhagia. It causes amenorrhea. It doesn't cause tachycardia. If you see the med score, in med score, we said heart rate less than 40 we need to consider. Sorry, less than 40 we need to consider as one of the risk factors in an eating disorder patients. So they usually present with bradycardia, not tachycardia. So all the symptoms, majority of them are getting fitted into the anemia rather than anorexia nervosa. That's why I'm not choosing the eating disorder, choosing the anemia over the eating disorder. Multiple episodes of neck spasms since morning. The patient is a known case of schizophrenia. Most probable diagnosis they are asking. So antipsychotic medications with neck spasms, acute dystonia is the most likely diagnosis. 70 years old, has fallen down, sustained an injury to the right thigh. Pain in the right thigh is complaining. X-ray confirms that there is a distal femur fracture is presented with agitation and aggression. Which one of the following is the next best step? What is the likely cause? We have a cause here. This patient has an ABD presentation, but likely underlying cause, we already have it. It is the pain what the patient is having. If we can easily manage the pain, the patient should be better. So, which one can give a good painkiller for a distal femur fracture? Neck of fascia iliaca block is the neck of femur fracture. We give it, so it is useless. Doesn't have benzodiazepine, doesn't have any pain analgesic effect or painkiller effect. Similarly, haloperidol also doesn't have any analgesic effect. Femoral nerve block, can we give this? No, this doesn't cause, or it is not effective to a distal femur fracture. Ketamine is an ideal drug here. It can treat the ABD symptoms what are having. At the same time, it has an analgesic effect. So give ketamine. Alcohol dependent, his last drink was 36 hours ago. Yes, presented to the emergency department with sweating, tremors, agitation. So it is an alcohol withdrawal. Next step, what they are asking, alcohol withdrawal. Next step, you usually give benzodiazepines. Out of these options, benzodiazepine is diazepam what they are given. You can give it per orally if the patient is cooperative, not cooperative, intravenous. Even sometimes intramuscular can be given if they are very much agitated. These are the important questions, few tricky questions which have appeared in the last slide. The most difficult questions in the last that has appeared from psychiatry and environmental emergencies. Okay, these are the specific questions which have appeared in the last date, what we are discussing from now on. We have a 19 years old female with a known case of ADHD, okay, attention deficit hyperactive disorder, is brought to the emergency department after the neighbors reports her behavior, irrational behavior, including fighting with her dog. So kind of very odd, bizarre behavior who is fighting with a dog. The most likely contributing factor for developing conduct disorder is, this is a conduct disorder, something abnormal what the patient is doing. Which is the most misconduct is because of conduct disorder, or the misconduct we basically call it as. Misconduct can be seen because of peer influence. Friend says do something, if you do this you will be very famous in the college. They kind of do a misconduct. You fight with a dog, you'll become very famous. So peer influence can have. Lack of parental supervision. There's a lack of parenting is there that can contribute to misconduct. Parents educate, go and steal. Yeah, yeah, stole. It's fine. Nothing. Don't worry. It's a normal thing. If parents doesn't teach the children, can result in misconduct, emotional and psychological issues if they are having breakup. They are having bad breakup with their boyfriend, so end up they want to vent it. They're venting on a dog here in this situation. Academic difficulties. They're just not able to cope up with the academics. Not able to match with their peers at that point of time. Substance abuse, like in cocaine, ecstasy, can cause this one. Exposure to violence, especially the physical violence, especially if there is a domestic violence, including trauma. Poor social skills. They do not know how to talk at all. Poor social skills. All this can lead to misconduct. So, out of this following, which is one is the misconduct? Social isolation is one of the misconduct factors we need to consider here. So, social isolations can lead to a misconduct. Female sex, no. High mid, no. And adult supervision, adequate helpful supervision is actually good. It prevents misconduct. Good social skills actually prevents misconduct. Social isolations can result in misconduct. Okay, this one was the difficult question which had appeared in the last diet. This was on the radioactive. So he accidentally consumed radioactive liquid that was an alpha emitter, what he had mentioned. Mistaken it for an water, and he has drank it. Came to the emergency department shortly after the invasion. Patient currently denies any symptoms, completely stable. What is the next best step in the management of this patient? What you'll be doing. First step is your own protection. He has taken an radioactive liquid here. Radioactive substance is not an emitter what you are having. It's not an exposure to the gamma radiation or the X-ray radiations. It's a liquid, radioactive liquid it is. So you need to protect yourself. Otherwise, you also will get affected. So wear PPEs before. Perform gastric lavage. Usually we do not do. Second step is do and wet decontamination. Dry contamination, we do not do it here. Treated with potassium iodide. It might be the treatment here, but again, we need to involve the physicians, specialist physicians needs to be involved here. A 18 years old female was brought to the emergency department with complaints of refusing to eat. Her recent medical records indicate a diagnosis of anorexia nervosa. According to MET criteria, which one of the following criteria is a high risk for the patient? High risk. So she's already been diagnosed. First step is done. Second step, to look out the high risk factors. High risk factors, BM should be 13. Core body temperature, we learned 5. So 35.5 it is. 1 and 2 is for the weight loss. So 1 kg over 2 weeks, not zero point 0.5. Glucose levels less than 4. Is the glucose level what we consider less than 4? Hypoglycemia? No, it is less than 3 what we consider. It is a 3 what we are having. So the right answer here is bradycardia. That is the right answer here. A 47 years old male, a known case of COPD, was brought to the emergency department with an acute confusion. Whenever there is an acute confusion in COPD, we assume or we kind of start thinking there might be increased levels of arterial carbon dioxide levels that has resulted in altered sensorium or the confusion. This is known as, sorry, this is known as encephalopathy, or it is known as narcosis, carbon monoxide. Sorry, this is known as narcosis, we can see, or we call it as because of high levels of carbon dioxide, we can call it. His regular medications include steroid, which were recently started by the GP. He denies any worsening of the shortness of breath or cough. He has denied any worsening of shortness of breath and cough. That shouldn't cause new accumulation of carbon dioxide leading to a new confusion. So unlikely this is the cause here. In ED, his vital parameters are within normal limits. What is the most likely cause for the acute confusion? Acute confusion, delirium. Delirium is nothing but retention of carbon dioxide can cause delirious state. Yes, but here the COPD patient is quite of stable. So unlikely this is the right answer. Dementia is never an acute thing, it's an hyperacute thing. Sepsis. Nothing is suggestive of, especially the vital parameters are normal, you can rule out the sepsis. Hypercalcemia can present it. Again, nothing is suggestive of an hypercalcemia in this patient. Most common cause for hypercalcemia is a primary hyperparathyroidism followed by CA. This patient is not a CA, this patient is COPD. So we are again ruling it out. So by ruling it out, you can come out to the diagnosis that's steroid psychosis. So literature says that if you start on steroids, acutely, especially, they can develop psychosis. This is known as steroid psychosis. How to diagnose and delirium in the emergency department? Which one is the recommended one by the NICE guidelines? Okay, few of them have recalled saying that they mentioned nice, according to the nice, which one you diagnose here and which one not. It isn't 480 what you are having. So four A's are there, so we call it as in 480. Right answer is 480, not AMT or confusion assessment method that is preferred in ICU and post-op situations. We have in 67 years old male was brought to the emergency department with being agitation and aggression on the road. In the ED department, he threatened to injure the staff. Haloperidol was administered rap as in rapid tranquilization. Shouldn't have ketamine, should have, but they have done it. 30 minutes after the nurse noticed that they are experiencing painful vasal spasms. What is the most likely medication that is appropriate to reduce the spasms or reverse the spasms? So what are we thinking? Haloperidol. Haloperidol is an antipsychotic medication. These antipsychotic medications can cause acute dystonia. So acute dystonia treatment is procyclidine. So easy question this was. The police has brought a 22 years old female brought to the emergency department with aggression, fighting with the officer, and even has bitten one of them. The nurse has recorded the unable to record any vital parameters in this patient. Verbal de-escalations have failed. What is the next best step they're asking? So it is an ABD situation. Unsafe, I call it, because there is already an bite to the officer, so you can bite any of the staff members. So you need to do an rapid tranquilization. Rapid tranquilization, the drug of choice is ketamine. Out of this, ketamine is given. A 26 years old female with a known history of epilepsy and levetiracetam had the police called by her neighbors due to the concern about her strange behavior. After 2 hours of struggle with the police, she was brought to the MS department where the nurse was unable to obtain her vital signs because she was too combative. You have seen, you have been urgently called to assess the patient in the triage. What is the most likely cause for her ABD syndrome? What is the most likely cause for the ABD syndrome? They are asking, or ABD presentation, what the patient is asking, why this patient is having ABD syndrome. Serotonin syndrome must be taking one of the SSRIs or must be taking an MO inhibitors or must be on tricyclic antidepressant. So easily you can rule it out, that part. There is nowhere in the stem of the question mention of an head injury, so you can't assume that this patient is having an head injury. So again, you can rule out an head injury. She's not an antipsychotic medication, so you can rule out a neuroleptic malignant syndrome. You're left with anticholinergic syndrome and substance abuse. Anticholinergic syndrome can have it, but it's more likely to have an substance toxicity because of the age what you are considering. Okay, that's how you need to get it out. Because of the age, considering substance toxicity is the most likely than having an cholinergic syndrome, because substance toxicity is like an cocaine or, for example, an ecstasy. All are sympathomimetics, not anticholinergics. Anticholinergics you do not usually abuse. The sympathomimetics are the ones usually you abuse because it gives an euphoric effect. Okay, this patient might be having an euphoric effect. That's why they're having a strange affairs. That's why substance toxicity needs to be picked up. So carefully rule out the options. The best way to answer this kind of questions is rule out, think logically what you are having. A 24 years old woman was found unconscious in the bathroom of a pub by her friends, was brought her to the emergency department. Her friends report that she had consumed some alcohol. No known medical conditions. Her vital parameters as follows. Strikingly, I have one vital parameter which is quite abnormal, that is bradycardia. Pupils are fine. Which one of the following is the next best step in the management? Pupils is fine. Not opiate overdose. Naloxone is ruled out. Flumazenil, usually 14 breaths per minute is present. Flumazenil usually causes severe respiratory depression, but bradycardia is not seen in benzodiazepine overdose. So you can rule it out, this one also. Admit for observation or give. I will not admit or I will give. I will choose atropine here. Why atropine? There is any bradycardia, this low heart rate is present, plus any life-threatening feature is present. We need to consider this patient is unconscious. We can consider this as a syncope. Syncope is a life-threatening features. As we studied in our resuscitation chapter, this patient should receive an atropine because the patient is unconscious, significantly symptomatic, life-threatening feature is present. Plus, there is bradycardia. That is enough for us to give an atropine. Remember your previous class, resuscitation? Yes, this question should have been in resuscitation. Missed out, so I put up here. Okay, you need to think in that logical manner. When you're thinking of just psychiatry and answering just psychiatric questions, it becomes easier. If you stop thinking of the psychiatric questions, when we mix up questions, then it becomes difficult.